Good afternoon to all Iocconians. This is our third edition of International Oral Cancer Congress, and I, as a organizing chairman, on behalf of organizing committee, welcome you all today on the third day of International Oral Cancer Congress 2024. We have very, enlightening 2 days in the past. That is on day before yesterday and yesterday. We have already discussed with the social issues and the prevalence, incidence, and tobacco cessation, etc. yesterday. And there is, we are talking, we have already, covered most of the, diagnostic related issues where 2, 3 oral pathologists who addressed yesterday's session. So today I'll take you through what is the today's agenda, and we has one paper presentation, two paper presentation sessions, but due to the paper presenter from the faculty category, they has requested that they have some important work in their college, so one or two paper presenters who are not able to attend this paper presentation program, and they are not able to present the paper. So they are not able to join us now. So we supposed to start at 1:50, but I tried to reach one of our speaker, Dr. Smith Desai. He is not available on his phone since morning. I don't know what happened with him. So after that, Dr. Preeti will join. And then we have Dr. Atigel, Dr. Shadab, Dr. Bala Subramania, Dr. Anjan Kumar, Dr. Manish, and then Dr. Dilip will join. How the program will go through, I'll let you know that we have two, distinguished faculty from University of Peradeniya, Sri Lanka. They are also from our organizing committee, Dr. Manori Jaisinghe and Dr. Prasangi Peris. Dr. Manori Jaisinghe is a professor at Department of Prosthetic Dentistry, Faculty of Science, University of Peradeniya, and Dr. Prasangi Peris, she's a lecturer in Department of Oral Medicine and Periodontology, Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. So they would be chairing the session for first two sessions, Dr. Desai and Dr. Priti Chen. Then Dr. Ruwan Jaisinghe will join. He is the organizing secretary of this conference, International Oral Cancer Congress 2024, and he is a professor in chief in Department of Oral Medicine and Periodontology, University of Peradeniya, Faculty of Dental Sciences. So he will be, chairing the sessions of Dr. Atigel, Dr. Shadab, and Dr. Bala Subramaniam, and then I, as a organizing chairperson, would be, chairing the session of Dr. Anjan Kumar Shah and Dr. Manish Tiwari, and then at the end of the session, Dr. Dilip from Sri Lanka will join. So this is how our sessions will progress today, and so I'm just waiting for Dr. Smith, or if Dr. Smith is not available, I am waiting for Dr. Priti. I had just word with Dr. Priti. She would be joining in a while. So we are waiting for that. And then Dr. Atigel from University of Peradeniya, Department of Oral and Maxillofacial Surgery. He is a Dean Faculty of Dental Sciences would be joining. So with this brief introduction of Dr. Prasangi and Dr. Manori, she would be taking it through the sessions from here now. Dr. Manori and Dr. Peris, am I audible to you? Could you unmute your microphone and join the session?
Yes, sir, you are audible.
Yeah, okay. And Dr. Manori, are you there? Dr. Manori Jaisinghe, could you unmute your microphone and open your camera so that we'll take our sessions from now onwards.
Professor Manori is finding it's difficult to unmute the microphones.
She has entered with two devices.
I think I did it for her.
Acha.
Manoj, you will be able to speak now.
By the time our speakers join, there are, host is not allowing it says, just hold on. Uh, Manoj, yes. So Manori, I have made you a co-host. I think you can unmute yourself and you can open your camera. Can you disconnect and join again, Dr. Manori?
Thank you very much, Dr. Nurul. And it's a pleasure to join your team for the sessions. Dr. Nurul.
We can hear you.
Are we going to start with Dr. Preeti in the absence of Dr. Smith?
Even she has not joined it because Dr. Nurul has sent a message to join early.
Right.
We have to wait until one of the two will join.
Okay.
There is one announcement from the organizing committee. There is a, the Dr. Smith Desai is in OT actually. There's some emergency surgeries came and he got the call and he is there. And then Dr. Preeti Jain, she's supposed to join, but there is a big confusion. She thought that her talk is on 4th actually, even though we have shared multiple time and we have spoken, I have spoken in the morning and I have given the time, but she was under impression that her talk is on tomorrow, that is day 4th February. So she's also in OT. She's onco surgeon. So her surgery is being planned. So she won't come. So we'll start our session from paper presentation session. We have three faculties who would be joining from 2:45, and then our sessions begins. Meanwhile, if anybody, any faculty who want to present their paper, who are not scheduled and whose paper presentation is abstract is not being shortlisted, we are giving the opportunity if anybody having their any presentation ready, they can present here because we have time. At least we have say half an hour time. Otherwise, we are keeping a pause and then we'll join at 2:45 where our three faculties would be joining and then our sessions begin. After that, we have one Dr. Bala Subramaniam. He's also not keeping well. He's on antibiotics. So he's saying that he might be not available. So we have these speakers and two or three is dropped due to their emergency surgery and one is dropped due to he's not keeping well. So we'll have 4 or 5 speakers today. They would be coming apart from the faculties who are presenting the papers. I'm just reading out the name of the faculties. Dr. K. Roja Lakshmi, Dr. Vijaya Lakshmi Basa Varaddi, and Dr. Shantala Arun Kumar. These are the scheduled paper presentation today. Apart from that, anybody who want to present the paper, they can share their slide and they can present the paper among our audience. Otherwise, we are, we'll start by 2:45 with the paper presentation session. By the time anybody want to, share something, share any feedback and all, because they are all oral and health procedures. They are treating the patients, diagnosing the patients having oral cancer and their own experience and all. So anybody can share their experience. They can, because we can utilize the time and we can, then when our, scheduled time start, we'll do that. Anybody want to say anything, any their experience and all, in terms of any research study they did, or if you want to present any paper, because we have received some 100 papers and due to time constraint, we have shortlisted with the help of expert Dr. Manori and Dr. Teris. They have 8 papers in faculty categories and 8 paper in PG category is shortlisted. PG presentation is done on day 1. There were 7 presenters who presented their papers. 1 was, absent. And then yesterday we have 3 faculties who presented their paper. 5 faculties are scheduled today to present their paper in 2 slots. Due to unavailability of one presenter, we have clubbed them in a slot which is starting from 2:45. So we'll start by 2:45. It's a half an hour. They can take a break and we can join at 2:45. All the, Zoom is live. We are just, keep putting our microphone and camera off. But meanwhile, anybody want to share anything, they can share here. Dr. Manori, I have a word with Dr. Vijaya Lakshmi and Dr. Shantala. Both are there in the meeting room, and rather to start by 2:45 because then we have a hurry. So we are allotting the scheduled allotted time is for 10 minutes each, but we are giving them more time, and we are starting the first presentation of Dr. Vijaya Lakshmi. She is a faculty and she is presenting her paper. And with us, we have the two juries, two judges. Dr. Manori, I have already introduced Dr. Manori a short while back, and Dr. Peris. I'm just reintroducing both of them. Dr. Manori Jaisinghe is a professor in Department of Prosthetic Dentistry, Faculty of Dental Sciences, University of Redania, Sri Lanka. And Dr. Prasangi Peris, she's a lecturer in Department of Oral Medicine and Periodontology, Faculty of Dental Sciences, University of Redania, Sri Lanka. I think both our judges are in the meeting room and the paper presenters are also there. So let's utilize the time. And after these two presentations, we will start with our, the speaker's presentation. So I made Dr. Vijaya Lakshmi a co-host. Dr. Vijaya Lakshmi, you can share your slide. You can give your brief introduction and you can begin your presentation. And after that, I'll call Dr. Shantala Arun Kumar to start her presentation.
Are my slides seen, sir?
Yes, your slide is visible.
Yes. Okay. Good afternoon, everyone. I'm Dr. Vijaya Lakshmi Basareddy. I'm Associate Professor in the Department of Oral Medicine and Radiology, SDM College of Dental Sciences, which is a constituent unit of Sri Dharmasthala Manjunatheshwara University, Dharwad. Today, I'll be giving a brief review on non-invasive techniques for detection and diagnosis of oral potentially malignant disorders. Starting with introduction, oral cancer is the sixth most cancer worldwide, and annual incidence rate of oral cancer is 36.2 million, and the death rate is around 8.2 million all over the world. India is the third most common cancer, which accounts for about 30% of all types of cancers comparatively. Despite advances in cancer therapies, oral malignancies have high mortality and morbidity rates due to varied reasons. And oral potentially malignant disorders are the group of conditions which include leukoplakia, erythroplakia, oral lichen planus, oral submucous fibrosis, palatal lesion associated with reverse smoking, actinic keratosis, and discoid lupus erythematosus. Oral potentially malignant disorders, they occur due to exogenous factors like tobacco, autoimmune disorders, or inherited genetic aberrations, which are prone to be increased risk for malignant transformation to oral cancer with lower survival rate for not being diagnosed at earlier stages. Here, as we dentists, we play an important role in detecting oral signs and symptoms of any disorder. And many a times, patients during their early stage of disease do not show up with any forms of signs and symptoms. In such cases, the primary goal is to diagnose the lesion properly. Early screening and advanced diagnostics tools play an important role in early diagnosis and treatment planning of patients suffering from oral cancer. So these are some non-invasive techniques in the diagnosis of oral cancer, which include clinical methods such as intravital staining, the vital tissue staining, cytopathological examination, which mainly includes exfoliative cytology, breast biopsy, etc. Some visualization adjuncts such as Wellscope, tissue autofluorescence, which includes chemiluminescence, and photodiagnostic methods. Now, starting with clinical methods, that is intravital staining. Intravital staining is most simple, inexpensive, and sensitive tool for identifying oral epithelial dysplasia and early squamous cell carcinoma. These mainly include toluidine blue, Lugol's iodine, methylene blue, rose Bengal dye, and acetic acid. And among this, the toluidine blue is most commonly used. Toluidine blue, it mainly binds to the nuclear material of tissues having high DNA and RNA content. For intraoral usage, 1% of toluidine blue is most commonly used. And these are some steps which are followed. After oral examination, the mouth is rinsed twice with water for 20 seconds to remove the debris. And this is followed by application of 1% acetic acid for 20 seconds to remove the saliva. This is again followed by application of 1% of toluidine blue solution for 20 seconds with cotton swab, and then followed by application of 1% acetic acid to reduce the restraint stain. And then it is followed by rinsing the oral cavity with water. And after this procedure, it looks something like this. And the area which takes up the deep blue stain is the area for the site of selection of biopsy. And the interpretation is done as dark blue or royal or navy blue stain of either the entire lesion or portion of that lesion is considered to be positive. And that lesion which doesn't take up the stain is considered to be negative. Now, Lugol's iodine is named after the French physician Lugol, and it gives brown color change, which can be noticed when applied on the normal epithelium. The vital dye with Lugol solution is also called as Schiller's test. In contrary to the toluidine blue, here the normal mucosa takes up the stain, and you can see the brown stain which is taken up by the normal mucosa. Now, moving on to cytopathological method, the first is exfoliative cytology, and this was first introduced by Nevon et al. And here, this the swab or wooden spatula or brush is used, and it is placed onto the surface of the epithelium and rotated against the mucosal surface. By doing this, the cells are collected. Here, after brush is swept, the epithelial cells which are loosely available for the study are available on the brush or the spatula. It is then fixed and viewed under microscope. This can detect epithelial dysplasia, carcinoma, and atypical changes during the early stages of cancer. Next is brush biopsy. This was first developed in 1999, and this has special kit which is supplied to investigators, which consists of oral brush biopsy instrument, pre-coded glass slide, and matching coded test requisition form, an alcohol or polyethylene glycol fixative pouch, and a pre-addressed container to submit the contents. And detecting the sensitivity of epithelial dysplasia or oral squamous cell carcinoma with brush biopsy is relatively high. And this is a specially designed brush which is used for taking the sample. Visualization adjuncts, these are mainly light-based oral cancer screening aids which are used for detection of dysplasia and malignancy. It mainly includes a Wellscope. This is a Wellscope machine. It is handheld portable device which is based on narrow emission tissue fluorescence, which provides light in the range of 400 to 460 nanometers. Under the intense blue light, the normal mucosa mainly is pale green autofluorescence, while suspicious tissue appears dark. Now, this is a clinical picture which was undetected by the normal examination. On Wellscope, we can see that the area which is the area of interest, which appears dark when Wellscope was used. Now, moving to chemiluminescence, this mainly is a technique which emits a light by chemical reaction, and Visilight is the instrument which uses this technique, and it emits bluish white light with the wavelength of 430 to 580 nanometers. Under this, the patient is asked to rinse 1% acetic acid solution to remove debris. And when the Visilight is used, the normal mucosa appears blue, whereas abnormal mucosa, it appears white with brighter, sharper, more distinct margins as it reflects the light. Now, this area is depicting a lesion. Now, we can see that the light is getting penetrated in the normal mucosa, where it gets reflected back in the area where the lesion is seen. And the sensitivity with this technique is about 100%. Now, some photodiagnostic methods. Oral mucosa, in this technique, the oral mucosa is illuminated with intense blue light wavelength ranging from 400 to 460 nanometers. When illuminated with blue light, the normal mucosa appears pale green compared to abnormal mucosa, which appears darker due to altered structure and cellular metabolism of epithelium and subepithelial stroma. And sensitivity with this kind of technique is 97 to 98%, and specificity is 94 to 100%. And example, and the instrument which is used is Microlux. Now, this is a chart which shows a diagnostic protocol for diagnosing oral potentially malignant disorders. Now, whenever there is a suspicious lesion, first it is examined with well scope, and if well scope shows positive lesion, then it is stained with toluidine blue staining. And after toluidine blue staining, if the lesion takes a positive stain, if the result is positive, then we have to advise for biopsy. And if it is negative, then we have to refer the patient to the specialist for confirmation of the diagnosis. And if it is negative on well scope examination, then again go for toluidine blue staining. And under toluidine blue staining, if the result is positive, then we have to refer to the specialist for confirmation of the diagnosis. And then if it is negative, the lesion or the patient has to be kept under regular follow-up at least for 1 to 2 months. Now, to conclude, early diagnosis of oral potentially malignant disorders is a prior health objective to prevent progression to oral cancers. Early detection should lead to less damage from cancer treatments and to a better prognosis. It is highly important to have clear knowledge about the usage of various diagnostic aids that can be used during chairside diagnosis mentioned here, which on proper usage can decrease the risk of morbidity and mortality associated with oral cancer. Thank you. These are my references.
ಅದು ಓಪನ್ ಮಾಡಿ ಹೌದಾ ಜಸ್ಟ್ ಓಪನ್ ಇಟ್ ನೋಡ್ರಿ ಅದನ್ನು ತಪ್ಪು ಸ್ಕ್ರೀನ್ ಶಾಟ್ ಎಲ್ಲಿ ಕೊಡ್ಬೇಕು ಅನ್ಸುತ್ತೆ ಐ ಥಿಂಕ್ ಶಿ ಹ್ಯಾಸ್ ಟು ಎಕ್ಸೆಪ್ಟ್ ಎಂಟೈರ್ ಸ್ಕ್ರೀನ್ ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿ
Yes, Dr. Shantala.
Yes, sir.
You are a co-host, you can join, you can share your slide.
Yes.
Can you make it a slide share show? Yeah, it's visible. You can start. Yeah, it's visible. Dr. Shantala, although we have allotted for faculty paper presentation 10 minutes, 8 minutes plus 2 minutes, but due to unavailability of other speakers and other presenters, so you have more time. You can present your slides in say another 20 minutes or 25 minutes. Can you unmute your microphone, Dr. Shanti?
Can you hear me, sir?
Yeah,
Am I audible?
Yeah, you are audible.
Yeah. I'm yeah. I'm Dr. Shantala Arun Kumar, Associate Professor from the Department of Oral Medicine and Radiology, SDM College of Dental Sciences and Hospital. It's a constituent unit of Sri Dharmasala Manjunatheshwara University, Dharwad, Karnataka. Today, I'm here to present my paper presentation, which is a research paper, which is on role of oxidative stress in the etiopathogenesis of oral submucous fibrosis, a preliminary prospective study. As we all know that oral submucous fibrosis is a chronic oral potentially malignant disorder affecting the oral cavity and oral pharynx. Mainly, it is seen in the South Asian populations. Clinically, signs and symptoms include trismus, restricted tongue protrusion, burning mouth, marble-like appearance of the oral mucosa. It may be associated with xerostomia, recurrent ulcerations, atrophy of the tongue papillae, and presence of palpable fibrous bands in the buccal mucosa as well as in the labial mucosa. These oral complications are fundamentally due to changes which happen in the submucosa, that is, especially in the zucta epithelial inflammatory reactions, leading to fibroelastic changes of the lamina propria in the oral mucosa and subsequently to the stiffness of the oral mucosa, which subsequently affects the patient's quality of life, mainly by reducing their ability to eat and speak because of fibrosis of the oral mucosa. There is going to be trismus. It's been it is also called by different terminologies. It's also called as atrophia idiopathica mucosae oris, oral mucous submucous fibrosis, diffuse oral submucous fibrosis, idiopathic scleroderma of mouth, sclerosing stomatitis, juncta epithelial fibrosis, or Asian sideropenic dysphagia. Coming to epidemiology, it affects up to 0.4% of Indian population, especially the south region of India. Incidence is rising, especially amongst younger population. This is mainly because of various habits like smoking, smokeless type of tobacco habit, and also because of increase in the alcohol intake. These are the various etiological factors which are proposed. It is a multifactorial in origin. Predisposing factors are local irritants like capsaicin, usage of areca nut, tobacco, alcohol, spicy food, or maybe because of changes in the salivary constituents in the patient's mouth. Systemic factors are also proposed for are one of the etiological factors for OSMF. There may be an associated factors like nutritional deficiency, especially the iron deficiency, infections, autoimmune disorders or autoimmunity, or many patients may have a genetic susceptibility to develop OSMF. These are the common causes for oral submucous fibrosis. This betel quid, pan, keni, different preparations, tobacco preparations like keni, mishri, zarda, mawa, nasa, etc. How this areca nut is mainly going to cause this fibrosis in the oral cavity? It is mainly because of the contents which are present in the areca nut, like alkaloids, flavonoids, and also copper. Alkaloids, they mainly stimulate the fibroblast which are present in the oral mucosa. If there is a associated, there is going to be gene expression which increases the production of collagen in the oral mucosa. That causes fibrosis of the oral mucosa. And we have one more content in the areca nut, that is flavonoids. It mainly increases the cross linkage of the collagen which is present. So there is going to be resistant, these fibers, they become resistant to collagenase. And we have areca nut also has copper which increases the lysol oxidation activity. So that stimulates the fibrogenesis. So all these together, they cause fibrosis of the oral mucosa, leading to oral submucous fibrosis. So again, further when it progresses, there is going to be juxtaepithelial hyalinization. So there is going to be, because of hyalinization, there is going to be vascular obliteration, so leading to reduced blood supply to the mucosa. That is one of the again cause for interfering the reparative action of the oral mucosa. When it continues, this habit, when it continues, there is going to be overactivity of all these cells leading to muscle contracture. So this again leads to more of fibrosis and scarring of the muscles of facial face, and also the muscles which are present around the mouth. Tobacco, as you all know, it contains nicotine and not nicotine. Mainly, there are N-nitrosamino, nitrosordicon, where we have more than thousands of these chemicals which are present in the tobacco. Coming to clinical features, it is most commonly seen in 20 to 40 years of age group. Sex, it is seen in both the sexes, but what we have seen is in males in Indian population, it is more compared to females, maybe because of more than one habit. The site being, the common site is buccal mucosa, retromolar region, soft palate, facial pillars, uvula, and also labial mucosa. Early signs of oral submucous fibrosis, initially patient will experience change in the taste, or sometimes there may be burning sensation, and all these things. So later, once it advances, there is going to be more fibrosis in the mucosa, leading to difficulty in protruding the tongue, and speaking, swallowing, and even at later stages it becomes so difficult even for the mastication. And even if patient is swallowing the content, so it might also affect the oropharynx, leading to difficulty in swallowing also. Coming to stages of OSMF, BAT AR, Dolakia HM, they've given a staging. Grade 1 says that mild cases with a very slight fibrous bands and little closure of the mouth. Grade 2, it is a moderate pronounced symptoms of diseases with fibrous banding extending from cheeks to the palatal region. Grade 3, it is markedly excessive amount of fibrosis involving cheeks, palate, uvula, tongue, lips, and also there is going to be the narrow opening of the mouth. That is commonly called as fish mouth appearance. Gupta et al. Has given one more classification. It shows that very early stage, usually patients will have burning sensation in the mouth or ulceration without difficulty in opening the mouth. There is going to be only ulcerations, whereas in early stage there is going to be burning sensation and also difficulty in opening the mouth. Moderately advanced stages cases will have marked trismus with the difficulty in mouth opening. It is usually less than 2 fingers. Advanced stages where you're going to be patient will be undernourished, having anemia, and has a marked degree of trismus, and or other symptoms like difficulty in having food, loss of appetite, other things. And Bailur and Nagesh in 1993, he has given classification where he has given as in the form of stages. Stage 1, he called it as early OSMF, where patient will have mild blanching, no restriction in mouth opening, no restriction in tongue protrusion, and burning sensation only on taking hot and spicy food. When we measure the cheek flexibility, usually we measure, we call it as V1 and V2 points. V1 point, V1 is nothing but it is a 2 points which measured between 1/3 of the distance from the angle of the mouth on a line joining the tragus of the ear and angle of the mouth. The subject is asked to blow the air, and we're going to measure that distance. V2, where patient is asked to release the air and the distance at rest, we're going to measure. This is going to be less in these cases. Stage 2, it is a moderate OSMF case where there is going to be reduced mouth opening, there is going to be burning sensation, and on palpation there are palpable bands, maybe in the buccal mucosa or in the orbicularis oris muscle. Because of the inflammation in the mucosa, because of ulcers, there is going to be lymphadenopathy, and there is going to be a marked anemia. Stage 3, it is a severe OSMF case where there is going to be all the symptoms or all the signs, they're going to be severe. They have severe burning sensation, and there is going to be reduced mouth opening, cheek flexibility, and also tongue is fixed to the floor of the mouth. And you can see, you could also see ulcerative lesions all over the mucosa, and the bands are going to be very thick, and there is going to be lymphadenopathy in the cervical group of lymph nodes. Whenever we get any patient, usually we advise for basic blood investigations. Usually we'll come to know that they will have reduced hemoglobin percentage. There is going to be increased ESR. Why increased ESR? It is also a chronic inflammatory condition. Obviously, the cells are going to be increased, and even there is going to be reduced vitamin B complex levels. There is going to be increased eosinophilic count. That is mainly because of its allergic reaction. What happens maybe because of the contents which are present in the tobacco preparations. There is going to be increased IgG. There is change in the salivary pH, and there is going to be increased salivary amylase, alkaline phosphatase, increased potassium, and there is going to be decreased calcium levels, and there is going to be hyperglobulinemia. That is mainly because of immunological changes which happens in the body. Coming to the management and how to confirm OSMF, if patient doesn't have any systemic sclerosis or history of any immunological disorders, we can go ahead with the incisional biopsy or punch biopsy to confirm the disease. And obviously, as a oral physician, first of all, have to talk to the patient to quit the habit. That comes under preventive measures. Initially only we can counsel the patient. Then along with that, we need to supplement with nutritional supplements like B12 especially, and also iron. And along with that, we also ask the patient to do some mouth opening exercises, especially to stretch the muscles of mastication and also facial muscles. So for that, we sometimes we might have to regularly recall the patient, and we should ask the patient to do in front of us, because many times we tell they don't follow it. So we have to first take a patient's for confidence. Then it becomes easy for us to help the patient to quit the habit. Other than that, we also prescribe antioxidants, that is mainly to reverse the oxidative stress levels, whatever is happening in the body. That I'll be talking in my paper in further slides. Apart from that, we have hot wave diathermy and microwave diathermy, all these things. And at last, in cases of stage 3, where patient is having very minimal mouth opening, we might have to refer the patient to oral surgeon for surgical excision of these bands called as fibrotomy. But surgical management, surgical treatment has its own complications like hair growth in the mouth and other things. And we do have nowadays, yeah, lasers giving good results for such cases. Apart from these things, we also have immunomodulatory drugs like the drug of choice being glucocorticoids. Initially, to reduce the burning sensation, we do give topical triamcinolone acetonide 0.1% or betamethasone 0.05%. When this burning sensation is severe, where patient is not able to have his daily diet, then we do give prednisolone for short time, starting with 20 milligram per day, dexamethasone 4 milligram per day, and triamcinolone 12 milligram per day. All these things, when we start, we have to we should know when we are going to stop the drug, so that we can't stop the drug abruptly. So we have to taper the dose slowly. Apart from that, yeah, interlesional injections we used to give for OSMF, but nowadays they say that wherever you give injection, that itself is going to increase the fibrosis, but it is not recommended nowadays. Other immunomodulatory drugs like placental extracts, levamisole, interferon gamma, immune milk, all these things are recommended. But usually, whenever we give intralesional steroids, we usually combine with placental extracts. Levamisole is given systemically; it's given in the form of tablets. Others like hyaluronidase, chymotrypsin, collagenase, and peripheral vasodilators are given. But every drug has got its own side effects. So before starting the treatment, we have to send the patient for general physical examination to know whether patient is fit to take all these medications, because peripheral vasodilators are and all we have to monitor while giving this medication. Coming to the research paper what I'm presenting, it is about the role of oxidative stress in the etiopathogenesis of oral submucous fibrosis. This is one thing we always have to know before we start with the treatment. What is the cause for developing fibrosis in cases of tobacco or areca nut chewers? Mainly, it so happens that not every patient develops this fibrosis. So why only in few patients they tend to have more fibrosis, and some patients will say that I just started since 2 years. But when we examine the patient, the mouth opening is going to be very less. Then it shows that there is something which is happening within the body. It may be a genetical predisposition. We cannot help it, but it has been it has shown that other than that there are some changes which are happening in the blood that we can detect by doing some blood investigations. So, oral submucous fibrosis is a chronic oral potentially malignant disorder. It is described as a scarring disease of the oral mucosa associated with excessive oxidants and insufficient antioxidants. While it is becoming increasingly accepted that oxidative stress results in excessive accumulation of collagen and progressive fibrosis of the submucosal tissues, there is a limited data regarding the moderation of oxidative stress to initiate or prevent OSMF. So, epidemiological studies have shown that process of carcinogenesis occurs by generation of reactive oxygen species, which act by initiating lipid peroxidation, preventing against lipid peroxidation. Mediated damage is done by non-enzymatic antioxidants, especially beta carotene and vitamin E, and enzymatic antioxidants like superoxide dismutase. That is why we give antioxidants in all these pre-malignant conditions and lesions. There's a reason why we supplement the patient. Oral submucous fibrosis, being a pre-malignant condition and associated with the carcinogens like tobacco, was thought to have some relation with ROS, and hence the present study was undertaken to assess blood levels of lipid peroxidation products in the blood. In the current scenario, pathogenesis of majority of the diseases is deeply linked with the oxidative stress. Irrespective of its etiology, innumerable data suggests that reactive oxygen species may play a major role in multi-stage carcinogenesis. Currently, the focus of pathogenesis is on the oxidative stress. Reactive oxygen species concerned with the multi-stage carcinogenesis are areca nut. The role of oxidative stress has not been widely investigated in OSMF. With this view, the present study was undertaken to estimate the total antioxidant activity, status, and also menaldehyde levels in the OSMF patients and controls. Coming to methodology, we included 40 subjects in that 20 OSMF patients, and 20 we compared with 20 controls. Patients were subjected for detailed history regarding systemic conditions. If at all patient is suffering from some systemic sclerosis or anemia and other things, psychological status to know what made them to get addicted to this habit duration, frequency of taking of tobacco, and quit keeping time in the oral cavity. A complete clinical examination was also recorded on a standard pro forma, followed by we did an incisional biopsy to confirm oral submucous fibrosis. And clinical staging was done based on the mouth opening, where stage 1 was considered as more if oral mouth opening is more than 40 millimeter, stage 2 when 31 to 40 millimeter, stage 3 when the mouth opening was 21 to 30, stage 4 when mouth opening was 11 to 20, stage 5 was considered when the mouth opening was 0 to 10 millimeter. Then histopathological grading was also done according to Utsunomiya et al. 5 millimeters of blood was drawn from each patient, both from the controls and OSMF patients, using aseptic measures, and samples were centrifuged at 3000 rpm for 10 minutes. Serum was separated immediately after blood centrifugation. Serum was used immediately for analysis. MDA estimation was done by using thiobarbituric acid method, and AOA was estimated using principle of TBA reactive substances by the calorimetric method. Data analysis was done by statistical package for social science software manufactured by IBM Corporation. Student t-test and ANOVA test were used for statistical analysis. Results were expressed as mean plus or minus standard deviation, and p-value was set as less than 0.05 was considered as a statistically significant. Coming to the results, the mean age of study population was 25.7 years with the age range of 18 to 38 years. All the patients in our study, they were all male patients. It has just happened that during our study, only male patients, they were had all the, this one for the inclusion criteria. Clinical staging based on the mouth opening, stage 1, among all these patients, 4 patients had stage 1, 6 patients had stage 2, 8 patients had stage 3, and 2 patients had stage 4 OSMF. Based on the histological grading, 5 patients were in the early stage, 7 patients were in the moderate stage, whereas 8 patients belong to intermediate and advanced stage. This is a table. What you see here, it is a comparison of serum AOA status between controls and cases. We had in this, you can see that in this present study, mean serum AOA status of OSMF patients was 1.51 plus or minus 0.52 millimoles per liter, and in control group it was 1.92 plus or minus 0.47 millimoles. The mean serum AOA status was significantly decreased in OSMF patients as compared to controls. There was no significant difference between mean AOA status among patients with different clinical staging and histological grading. This is a comparison of serum MDA status between controls and cases. The mean serum MDA levels among OSMF patients was 3.60 plus or minus 0.91 nanomoles per ml, and in control group it was 1.78 plus or minus 0.43 nanomoles per ml. The increase in the mean serum MDA level was highly significant in OSMF patients as compared to controls. However, no significant difference was noted in serum MDA levels among different clinical staging and histopathological grading. Coming to discussion, in the present study, mean serum AOA status in OSMF patients was significantly lower than that of the control group, with the mean reduction of 0.41 millimoles per liter in OSMF patients. Serum AOA status was compared with the different clinical and histopathological grading, and there was no significant difference was noted. Reduced antioxidant status noticed in our patients may be attributed to excessive utilization of antioxidants from the body in order to scavenge the free radicals generated during the pathogenesis of the disease. Reduced intake of food due to decreased mouth opening and burning sensation could also be another contributing factor. To the best of our knowledge, there is no published data were found where total AOE status has been estimated in OSMF patients. However, observations from present study were in accordance with other studies where individual antioxidant levels have been estimated. Gupta et al. Observed that serum beta carotene and vitamin E levels were considerably reduced in OSMF as compared to controls. Metcari et al. Noticed that superoxide dismutase and vitamin A levels were reduced in OSMF as compared to controls. Mean serum MDA levels in OSMF patients were considerably increased as compared to controls, with a mean difference of 1.82 nanomoles per ml, and the difference was statistically highly significant with a p-value of less than 0.01. Increased MDA noticed in our study can be credited to the oxidative stress taking place in the OSMF patients, as demonstrated by increased heat shock protein, head-out immersion, and nitric acid synthetase. The detection of products of lipid peroxidation in biological materials has provided the basis for several popular assays for ROS and determining the involvement of oxidative stress in the pathogenesis of particular disease. Results from the current study are in accordance with the various other studies like Gupta et al., Metcari et al., who noticed increase in the MDA levels in OSMF patients. With this, I would like to conclude that from our study, it is evident that by estimating lipid peroxidation end product and total AOE status in serum of OSMF patients, we can estimate the amount of oxidative stress tissues. Tissues are oxidative stress. Tissues are undergoing during the process of pathogenesis. Hence, the administration of antioxidant supplements may be helpful in combating the disease. Further trials in this regard should be carried out to investigate the probable mechanisms by which ROS contributes for pathogenesis of OSMF. A long-term follow-up studies have to be carried out in order to draw a link between oxidative stress and malignant transformation in cases of oral submucous fibrosis patients. These are all my references. Thank you.
Great presentation, Dr. Chansla. Dr. Marori and Dr. Paris, could you please ask
Thank you, sir.
questions here?
Thank you very much, Dr. Shantala. It's very descriptive
Yes,
and very elaborated presentation.
Thank you, ma'am.
If actually, I don't have any questions regarding the presentation.
Dr. Manori, can you ask question? If you have any query apart from this, if any among any our attendees, if you want to know store further, they can ask it. So, Dr. Ruwan, are you there?
Yes, I am here.
So we have 10 minutes. 3:45, 3:15 is the time scheduled for Dr. Attigal. So I think he would be joining in a while.
Yeah.
And then from there we'll have the other speakers and all.
May I ask a question from Dr. Santala?
Yeah.
And Santala,
Yes.
this is regarding your sample
sir.
size. Now you have taken 20 from the control group
Yes,
and
sir.
the 20 OSF. Now this 20, have you done a power calculation and identified the number as proper sample size calculation, or for the convenience you have selected 20 as the sample?
Actually, it is according to the convenience. We
Okay.
did not do the power calculation,
Sure.
sir.
Now, for this presentation, it will be fine. But if you are
Yes.
thinking of going for a proper publication, I think you need to have a sample size calculation and the power calculation and then go it. Otherwise, a publication will be a difficulty. And
Yes.
you have good results, and these results can be taken as a pilot study. And
Yes.
so, my advice is for you to do a proper sample size calculation and go ahead with the study, because your study looks very interesting, and I'm sure you
Yes.
will come across very good results, which is definitely publishable.
Yes, so that's what in literature we see very few studies which are done on oxidative stress levels. So that's what I'm thinking, sir. I mean, to continue this study. I mean, I've been continuing this study, sir, and I'm thinking like I'll include more and more patients and from different parts of Karnataka, sir, because
Right.
in some regions it is tobacco usage is too much, sir. So I want to know where in certain places where the usage is less and mostly they use this raw tobacco, sir.
Yep.
But in North Karnataka, when you see, they use more of tobacco preparations. So when you go towards South, they use more of raw tobacco, sir. So I wanted to, include and, I'm applying for some funds, sir, so that it becomes easy for me to do it in large scale, sir.
Yeah. And in addition to that, you can consider looking at the histopathology and try to
Yes, sir.
relate the histopathological findings now, whether these changes are different from OSF without dysplasia and OSF with dysplasia. So if you can
Yes, sir.
have your clinical, histopathological, as well as the etiology factors all three together, then the results will be much more stronger.
Yes. So, yeah, that's a good suggestion, sir. Yes.
Thank you. Good luck. Good luck with your work.
Thank you so much, sir. Thank you.
We have one presenter, Dr. Roja Lakshmi, in our meeting room. I think she was saying that she is having problem for sharing the slides and all. She logged in with the mobile. Now I think she is logged in with their system. Dr. Roja Lakshmi, if you want to share your slide, you can share. Or if you want to let extempore what your study was. Because we have still 6-7 minutes to our next speaker.
One second, sir. I'm sharing the PPT.
Yeah, it's visible.
Sir, are you able to see my presentation?
Yeah, we are able to see your presentation. You move ahead. Go ahead, give
So good
your
afternoon,
brief
everybody.
introduction and start your presentation.
So good afternoon, everybody. Today my presentation is on bioinformatic analysis of differentially expressed genes and potential microRNAs in OLP and OSCC. So as everybody knows, OLP is a chronic inflammatory process, and oral squamous cell carcinoma is a malignant epithelial tumor. So there is a scientific literature that if there is, chronic inflammation can lead to malignant transformation of any chronic inflammatory process can trigger the formation of oral squamous cell carcinoma. Hence, my study intend to study about the common pathways which are there in oral lichen planus as well as OSSs. So my materials and method include we collected geo data sets. The patient data is taken from a database. So from there, we'll take some samples of patients of oral lichen planus and some samples of oral squamous cell carcinoma. And the data is processed and we'll identify the differentially expressed genes through an online tool which is called as Geo2R Analyzer. So upon analyzing the differentially expressed genes, the common genes are again identified using FunRich software. So with the help of FunRich software, we are able to identify the genes which are upregulated in both oral lichen planus and OSCC, and the downregulated genes are also identified using this FunRich software. So next, upon identification of the genes, we intend to read further the molecular functions and the pathways of these genes and the cellular components and the molecular components involved in it. For this, again, we use Enricher software through which we can read the pathways of the common genes from both oral lichen planus and oral squamous cell carcinomas. So upon identification of this, we'll come to know what are the genes as such are implicated for the malignant transformation of oral lichen planus and oral squamous cell carcinoma, and what are the possible proteins involved, and what is the signaling pathway that is involved in this. So what will be, which genes are upregulated and downregulated. So the common differentially expressed genes again are subjected to protein-protein interaction analysis using string database. So upon protein-protein network analysis, will be able to identify the hub genes by using a plugin which is called as the CytoHub. So based on these applications, we'll be able to identify the hub genes. So upon identifying the hub genes, these hub genes are again kept, these identified genes are processed in MIRNet software. So we can see what are the microRNAs which are interacting with these genes. So upon, we can see in the results, so these are the normal versus oral lichen planus samples that are taken from the geodata sets. We can see oral lichen planus data set GSE 52130 and OSCC data set GSE 56142. So upon after undergoing this GO2R analysis, so we can normalize the data, and the genes which are which come in the form of Excel sheet, so they are entered into this fun rich tool. So here we can see 15 common genes we can see in the upregulated genes. So the genes are as follows: KLK 12, RNA 7. So like that we can see approximately 15 genes which are upregulated. And again here we can see 3 genes which are downregulated. So we can see the upregulated and downregulated genes. And upon analysis through the KEGG pathways, we can identify that these genes are also involved in different pathways, like in Staphylococcus aureus infections. Also, we can see the involvement of these genes, and glycosaminoglycan degradation you can see, and interleukin 17 signaling pathway also we can see these genes. So all this, the identification of this particular pathway is indicating that there is these genes are also involved in a antimicrobial response, as well as the glycosaminoglycan degradation, which again are related to immune responses of the cells. So in downregulated genes, you can see the biosynthesis and the metabolisms of amino acids such as alanine, aspartate, glutamine. So these are the downregulated pathways. So next, coming to the biological process. So we can see the upregulated biological processes includes defense response to bacterial diseases, and intermediate filament organization and antimicrobial humoral responses. Even iron coordination entity transport is also upregulated. So these all may contribute to the inflammatory microenvironment of oral lichen planus and may lead to the subsequent development of OSCC. So again, here we can see the same metabolic process involved here of the amino acids. So these are the downregulated biological process. So next, coming to the cellular process. So all this are usually seen in the granules or filaments and secretory. Usually the cellular processes that are upregulated includes the granules or filaments and other secretory process. So again, which may cause alterations in the cell behavior, so potentially leading to malignant transformation. So the downregulated cellular process includes keratin filaments, intermediate filaments, and cytoskeleton also is downregulated here, which may result in the cellular adhesion abnormalities as such. So coming to the molecular mechanisms, you can see serine type endopeptidases, chemoreceptor binding, and metallo and peptidases inhibitor activity as a upregulated process. And in downregulation, you can see amino acid bindings. So these all indicate that these changes may influence the cell signaling, cell migration, extracellular matrix interactions. So this upregulated mechanisms may contribute to the alterations in the immune responses, alteration in the cell morphology and function, and it may lead to the molecular activities. Whereas the down-regulated pathways, they are mainly involved in the metabolic processes, such as aspartate, arginine, glutamine metabolic processes. So, and even in the some elements are seen even in the neural transmission, potentially influencing the progression of oral lichen planus to OSCC. And there may be environmental factors also, which can contribute the malignant transformation of oral lichen planus to OSCC development. And as you see, keratin filaments, intermediate filament cytoskeletons are also involved, which may affect the cell structure, motility, and communications. So potentially influencing the invasive behavior of this transformed cells. So next, going to the protein-protein interactions, we can see that the genes are linked with some protein molecules, and upon identifying the hub genes, these are the hub genes that you can see, LCN2, KLK12. So these are the 7 hub genes that are identified, so which can potentially result in the malignant transformation of oral lichen planus to oral squamous cell carcinomas. So next, coming to the mRNAs. So here you can see HSA MER 138-5P. So it is usually involved in the cellular process, including the cell proliferation, apoptosis, and migration processes. So indicating that this gene, this mRNA dysregulation also can contribute to the malignant transformation of oral lichen planus to oral squamous cell carcinoma. So next, coming to other mRNA. So here you can see HSCA MER 200C3P. So which is mainly involved in the epithelial mesenchymal transition, and which may be a very important mRNA contributing for cell, cancer metastasis. So summarizing my findings. So if there is any inflammatory trigger or inflammatory microenvironment along with the bacterial inflammatory process, so we can see cellular and morphological changes and cytoskeletal disruption. That is, the normal cell will convert into abnormal cells. So as we have seen in the study that there are increased intermediate filament organization and reduced cytoskeletal elements. So next, which may lead to the molecular signaling alterations also, which can finally result in the dysregulation of cell signaling, migration, and interaction, and extracellular matrix interactions. And finally, it can contribute to the transformation of oral lichen planus to oral squamous cell carcinoma. So my conclusion is that by identifying the differentially expressed genes and the proteins that are involved and the pathways that are affected, and identifying the micro RNAs, so it can result in a better choice of drugs. We can target, specific drugs can be targeted against the specific genes. So it can have implications in personalized medicine. Thank you.
Nice presentation, Dr. Roja Lakshmi. Dr. Manori and Dr. Hades, if you have any question, you can ask. Otherwise, then we'll move to our next speaker, because Dr. Atigali, I think, anything will.
I will ask a very quick question.
Yeah, Dr. Ruwan.
Now, the malignant transformation of oral leukoplanas, how common that is in India? Do you see the cases commonly, or is it something very rare?
It is not that common, sir. It is relatively less. But however, I mean, even there are studies that this inflammatory process is the trigger for formation of cancer. So actually, I had one other study where periodontitis, chronic inflammation, which is also chronic inflammatory, can result in OSCC. So I thought of taking that as whether this chronic inflammation is truly has this chances to convert into cancer or no. So
Sure. I am not. Your study is very good and all that. I am not commenting on the study and the importance of it. I just want to know the malignant transformation, because the literature is very confusing. Different places are having different rates, whereas ours the rate is extremely low. We hardly get
yes, sir. Yes, sir.
OLP case transform into the malignance, whereas in the Western countries, especially in the Europe, the malignant transformation rate is quite high. So that
Yes,
is why
sir.
I want to know whether the
It
US
is
situation you
relatively less,
experience,
sir,
whether
as
it is
it
high.
comes to. No, sir. No, it is relatively less when compared to.
Okay, right. Thank you.
Okay, sir.
So
Can I
over to
ask
you,
one
Ruwan,
question?
to take it forward from here.
Yes. Thank you, Dr. Nurul, and thank you, Dr. Prasangia and Professor Manori, for conducting the faculty presentation session. So we will move to the next speaker, and I am honored and privileged to introduce our Dean of the Faculty, Professor Manjula Attigala. Professor Manjula Attigala is a very experienced clinician, oral and maxillofacial surgeon with a vast experience, especially in the field of oral cancer, the reconstruction, especially the microvascular reconstruction. Professor Artigala is a board-certified consultant in oral and maxillofacial surgery, and currently he is holding the post of Chair Professor of Oral and Maxillofacial Surgery, the Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, University of Peradeniya. And not only that, currently he is the Dean of the Faculty. In addition to his university academic position, he has held many positions in the past, um, including the chairmanship of the Board of Study in Dental Surgery at the Postgraduate Institute of Medicine, and he is a member to the Sri Lanka Medical Council, and so many administrative responsibilities. He is a keen teacher as well as a very good researcher with large number of presentations and publications in both national and international level. So without taking much of your valuable time, may I invite Professor Manjula Attigala to go ahead with his presentation. Over to you, sir. We can't hear you, sir. Dr. Nurul, I think you may have to make him co-host.
No, I have already made him
Right.
co-host. You look at that, he's a co-host. And
yeah.
There's only one by name of Dr. Manjula Attigala, only one name.
Yeah.
So I have made him co-host, and
Sure.
he's unmute mode, but I don't know why we are not able to hear him. There is some issue in his device. Yeah.
Professor Attigala, can you hear us? We can't hear you.
Dr. Ruwan, can you request Dr. Manjula to sign off and then
Sure.
rejoin again?
Attigala, sir, can you hear me? I think we can't hear you, so the best thing is for you to log out and rejoin.
Otherwise, you can inform him through WhatsApp message.
Yeah,
or
that's
a
what I'm
phone.
going to do.
Yeah, please. Maybe he's not able to hear us.
මේ සර් පොඩ්ඩක් log out වෙලා ඉන්න සර්ගේ මේක වැඩ කරන්නේ මයික් එක. ඔව්. නෑ මේ ඕක මනෝරටත් උනා මේ log out වෙලා ආපහු sign in වෙන්න. I have given him the message, so he will join.
Yeah. I'm yes, he's joining.
The audience, please pardon with us.
Yeah, I think he's joining.
There is a little bit of a technical issue. We'll see.
His co-host now, he can share his slide. Dr. Manjula, you can share your slide. Manjula is unmute in position, but we are not able to hear him.
We can't hear you yet.
Can you?
Yes, now we can hear you.
Yes.
Yeah, I'm sorry about the technical issue.
Now you can share your
share?
slide, yes.
Yeah.
If you open your presentation and then press the share slide, share screen option.
That option is not shown here.
Are you
That
getting?
green.
Are you getting in the bottom a green color?
No, that's the thing. I'm not getting it actually. Share option is not there.
Share screen on the bottom, there is a green color icon. You are not able to look at it. Yes.
It's not available here. The green share option is not given here actually. I only have security, participants, chat, record, show captions, AI, reactions and settings and more.
You came by name of Manjula Attikal or any other
Yes.
name?
Yeah, Manjula article.
Just hold on. I'm just removing your co-host option and then again giving you the permission. Now see whether it is available or not. The green icon in the
Not
bottom.
yet. Not yet.
If that is the case, sir, can you email me the presentation so I will open from my side?
Yeah, sure. I don't know whether it can be emailed. I'll share now the presentation. I mean, email it to you.
Yeah.
Yahoo.com address.
Yep. Okay. I got it. Give me a second. Give me a few more seconds. It's opening up. As the size is too big, it takes a little bit of a time.
Until the
Yes,
until the presentation is open, may I just start with a brief introduction then?
Yes, it's visible.
Yeah, thank you very much. Right, because of the time, I will go straight into the presentation. I think.
Just give me a
Do
second,
I
sir.
have the right?
Dr. Ruwan, it is visible. If it is not going in a slideshow mode, Dr. Manjula can start.
Yeah, right.
Sliding
Thank you.
You can start. I'll get.
Yeah, I'm very sorry for the technical issue, and I was here. What I'm going to discuss is about the neck dissection in oral cavity cancer. Oral cavity cancer, I'm specifying it only up to the anterior pillar of fauces, anterior two-thirds of the tongue, and up to the hard palate, soft palate junction. So when you consider oral cavity cancer, it's obvious that neck dissection, neck regional metastasis has a significant influence on the outcome or the prognosis of the patient. So therefore, it is very important for us to assess properly and stage it properly, and then decide on the treatment plan and embark on that. And even after surgical management, the follow-up treatment accordingly, especially with the available histopathology report. So therefore, I think each stage we need to understand the pros and cons or difficulties a clinician might encounter. Can I go to the next slide, please? Yeah. So this is typical dissection of the tongue, especially anterior two-thirds of the tongue, and the concept of en bloc dissection of bilateral neck nodes. The moment it's involving the tongue, yeah, need to click again. Yeah, so the survival rate obviously drops by about 50%. So, and also in positive nodes, it's understood that the surgery is the choice. So, but the thing is, even clinically not involved or clinically negative neck, even there's a risk that we miss that, and making the poor prognosis at the over long periods of time. Next slide, please. Yeah. So as I mentioned, it's the most important and the impacting prognostic factor for cavity cancer or oral squamous cell carcinoma. And nodal involvement at the time of diagnosis more than 40%. So, but however, in Sri Lanka, it used to be little less than that, because most of the 60 odd percentage of the histopathology comes as well differentiated, and we used to see less number of neck involvement. But we have to see with the changing pattern of oral cancer whether it's still the case. And what is critical is, as I mentioned, the effective evaluation of neck and management in the case of elective neck dissection. Obviously, we know that from the oral cavity cancers, the metastasis into the neck nodes levels actually mainly into level 1 to 3, except in cases of tongue, flow of the mouth, etc., where level 4 involvement is high. So generally speaking, unless there is involvement, obvious clinical involvement of level 5, it's very, very rarely that we are embarking on dissection of the level 5, as well as in certain cases level 4. If it's clinically positive, it is mandatory to get involved with the level 1 to 4. But clinically negative neck, we usually address level 1 to 3, except in cases of tongue and floor of the mouth. Next slide, please. So this is just to show the clinically negative and the clinically positive neck. And I explained about the consequences earlier. What are the clinical evaluators of nodal diseases? Is the size matter, the location matter, and what are the factors involved in histopathology, which matters in assessing and deciding the neck management? Can we proceed, please? Yes. When you consider this, the size of the primary tumor, literature, according to literature, this is what it says. If it's less than T1, less than 15%, if it's T1, there is a less than 15% chance of neck involvement. T2, 15 to 30, and T3, 50%, and T4 cases more than 75%. According to some other authors, when in case of tongue, even T2, there is higher number of nodal involvement. Half of the cases have nodal metastasis. And even with T1 lesions, with depth of invasion is 4 millimeter, there is more than 20% of occult mets in case of tongue. So that makes us to think twice when we are dealing with tongue cancer. So therefore, the recommendation T2 to 4 cases, it is advisable all patients to have a neck dissection. In case of T1 lesions, if it's the DOI is more than 4 millimeter, it is generally better to make the decision of neck dissection, which I will give the literature support in the coming slides. How about the tumor subsite? There is increased risk from the anterior to the posterior aspect of the oral cavity, as well as upper to the lower in the upper aerodigestive tract, according to Beck and Rogers. And also Brokoff in 2017 states that site-specific location of oral cavity and association with DOI and nodal mets, I mean, if it's more than 20% of risk threshold is there. So, and as I mentioned earlier, the oral tongue mets are significant in that sense. Now, if you think of the histopathological features, which we have to think of, it has been discussed whether the invasion front grading has a significance, grade of differentiation, lymphovascular invasion, cohesive or dissolute invasion, and perineural invasion. So all these have been discussed with to a different degree, having evidence in various literature. But finally, it is the DOI which is significantly associated with disease-specific survival. Now, International Consortium for Outcome Research in Head and Neck Cancer, in a study based on 3,149 patients, which is an international multicentric study. Based on that, it says that DOI added to the T-stage determination. It is better to have that, to have the T-stage determination, and which is an independent factor, which is independent of the T-stage. So DOI is recognized as an independent factor other than the T stage for staging. Reflect proximity of, thank you. We have to think of the proximity of tumor to underlying lymphovascular structures. The DOI reflects that, the proximity of tumor to the underlying lymphovascular structures. Therefore, this is also not only to the tongue, but applicable to all oral sites. Next slide, please. So this is another study which gives DOI and the 20% cutoff. Now here, the decision to decision making cutoff for the neck dissection has been taken as 20%. So in tongue cases, it is 2 millimeter, and recommendation for neck dissection has been given as 2 millimeter as well. Whereas alveolus hard palate, it is 4 millimeters, and recommendation for neck dissection is about 3 to 4 millimeters. All in all sites, it is, according to this study, it's about 2 to 4 millimeters of DOI make it recommended for going for the neck dissection. Thank you. Another factor is the extranodal extension, or ENE, as a disease-specific survival determinant. So the Juno study, comprising of 1,190 patients, gives these values. When pathologically not with combined with negative extranodal extension, the prognostic 5-year survival is about 85.5%, whereas pathologically neck positive plus positive extranodal extension makes it less than 30%. If you go beyond that, the degree of extranodal extension, Weissman in 2016 stated, analyzing about 109 cases of extranodal extension, the critical distance outside of the node for clinical difference in disease-specific survival is about 1.7 millimeters. So ENE is also recognized as the independent adverse prognostic variable for regional node metastasis, in addition to number of nodes and size of nodes. So patients with less than 1.7 millimeter of ENE has around 49% of 5-year survival rate, whereas patients with extranodal extension of greater than 1.7 millimeters, it's critically less, about 8.5%. And depending on these, the modified neck classification with the inclusion of ENE for all non-viral related head and neck cancers have been developed except mucosal melanoma. A critical thing is to assess properly the next stage, next state actually, the preoperative diagnosis, evaluation. So there are various tools, including ultrasounds, scanning, and also CT, MRI, PET. So what is better? Is it CT or MRI? The standard presentation. So size, of course, is one determinant, and specific features in these investigations, such as rim enhancement and central necrosis and extranodal extension, may give an idea about nodal involvement, specifically with contrast enhancement. So it is important for us to go for a contrast enhanced CT or MRI to look at these specific features. Of course, there could be high accuracy of nodes larger than 1 centimeter, but limitation is sub-centimeter or microscopic METs is the challenge. Next slide, please. Now, if you look at this table, I'm sure that most of you may be aware, but for just for the completion's sake, this shows the reliability of different modalities of imaging for neck assessment. And when you look at ultrasound scan, CT, and MRI, MRI may have a slight specificity advantage and a marginal increase of accuracy, but obviously the US guided FNAC seems to be the best tool for available in this manner. When you come to imaging, to differentiate clinically negative and positive disease, accuracy of fine needle cytology has higher prediction value than other modalities. And also, obviously, rather than PET-CT, it's a better tool. And PET-CT and can we go back? PET-CT and CT also gives a comparable result. And as I have mentioned, when you compare ultrasound guided FNAC, you can see the sensitivity and specificity levels. Therefore, it can be assumed as the best way of assessing is in a case of clinically negative neck. Thank you. So that is based for these changes in the staging manual for OSCC. And depth of invasion, the cutoff as 5 millimeter, has been used to upstage the disease in case of increased depth of DOI value. And you can see the ENE value as well is the same as the DOI, that it upstaged the disease. When you look at the current classifications of neck dissections, typically it has been divided as comprehensive and selective. And comprehensive, it's radical in case of removal of all three structures, whereas, I mean, it is very, very rarely nowadays it's been done. Otherwise, there is gross neck disease, and always a conservative attempt is being made depending on the available evidence. Selective types are not that used in head and neck for oral cavity cancer. Selective lateral or anterolateral or posterolateral are not being used, and it is mostly selective level 1 to 3 or radical in case of positive necks. This shows the changes of classification ranging from 1991 up to 2008, and selective neck dissection, modified radical neck dissection, and radical neck dissection were the ones given in 91, and selective neck dissection, it has been graded according to the structure which is being sacrificed, and also in 2000 new recommendations, boundaries between the level 1 and 2 and 3, 4 and 6 are being reclassified, and terminology of the superior mediastinal nodes level has been identified as level 7. The method of submitting surgical specimen for pathologic analysis will be based on these assumptions. When we think of the treatment decisions in the management of neck, the crucial thing is the decision regarding the N0, clinically important, as for the patients with N positive. So occult meds make the neck, in case of even clinically negative, the histopathology, it comes as pathologically positive neck. So therefore, failure in addressing this fact will definitely lead to reduced prognostic consequences. Therefore, neck staging is critical. It is if there is any uncertainty in determining the state of the neck lymph nodes on initial staging, there could be in cases where even with modern diagnostic tools that we might miss the occult meds. So therefore, we have to go for evidence-based guidelines and recommendations with this regards. So what are these evidence-based? The cutoff mark we take as 20% possibility of neck involvement, probability of neck involvement. So for that, it is best to utilize whatever the denominators that we have. Definitely the DOI, and the DOI is one definite thing. Then depending on the population, depending on the research, we might have to decide on whether it's staging, site, the differentiation, and all other factors we need to combine. And with that, we have to go for decision making. What we usually do is overstaging. Next slide, please. So with all that, if you think of the survival benefits with elective neck dissection increases 3-year survival rate in case of T1 lesions of 49% and T2 lesions 75%. And also DOI is the only significant independent feature for the prediction of nodal mets, local recurrence, and also survival in patients with OSCC. And another study, occult disease had 5-fold increase in dying of the disease compared to others with no occult mets. So in that case, the incidence of occult mets were 28%. Next slide, please. This is a landmark paper. I'm sure that you may have gone through this as a Bible. De Cruz et al. In 2015, the survival benefit of elective neck dissection of T1 to T2, there was 12% overall survival over wait and watch policy. So 36% reduction in the risk of death, and also reduces neck recurrence by 55%. The techniques such as the sentinel node biopsy, where in Sri Lanka we are not in a position still to adopt it in a routine basis. This is one way of reducing the chance of neck dissections if proper equipment and available, then of course we could utilize, and there is enough literature to support that. And using sentinel biopsy, you can decide on the neck and more than assuming and going ahead with the neck dissection. We'll go for the other. Yeah. So therefore, in positive neck, it's easier to make the decision making because uh, uh, it's obvious, and there are certain modifications. The efficacy of selective neck dissection, even in the case of N positive neck, Cochrane analysis, there is no difference in radical neck dissection and a selective neck dissection in those case series. Therefore, some of the clinicians may be still using, even in radical in positive status, selective 1 to 3 or 1 to 4, depending on the site. So one can say that SND is possible in neck and positive. They said that there is a selective neck dissection is still possible in positive case, unless massive adenopathy, gross extracapsular spread, or history of previous surgery or radiotherapy. And post-op chemo and radiation is indicated for node-positive disease. So with that, I would like to conclude. Basically, in summary, what I would like to say is the neck involvement makes the prognosis, makes the oral cancer management a challenging one, and it is crucial for us to critically stage this disease. But unfortunately, depending on the availability of tools, it is difficult sometimes. So it is best, especially in cases of tongue and floor of the mouth, even in case of negative neck, to think of selective neck dissection. And contrastingly, even in the case of positive neck, it is possible to do selective neck dissection either 1 to 3 or 1 to 4, especially 1 to 4 in most of the sites. As it has been shown, the level 5 involvement is very, very rare. And depth of invasion and extranodal extension are crucial factors in which affects the prognosis of a oral cavity cancer patient. So again, I would like to thank the organizers giving me this opportunity, and thank you very much.
Thank you very much for your excellent presentation and enlightening us the importance of management of neck in patients with oral squamous cell carcinoma. I'm sure the audience got a very important message. Even though we are running short of a time, we can entertain 1 or 2 questions from the audience if they have any. In the absence of any other question, we would like to take this opportunity to thank Professor Artigala. Even though he is having a very busy schedule, he make it a point to come and go ahead with his presentation. Even with the technical hiccup, he managed to do it. Thank you very much, sir, for your excellent presentation.
Thank you. Thank you very much. Thanks again for
so as the time is a factor, we will straight away go with the next presentation. And I have honor and privilege to introduce the next speaker, who is having a long list of credits for his in his sleeves. And if I am going to tell all these credits, it will take a longer time than his lecture. So therefore, I will take only a few highlights from his career achievements. We have none other than Professor Shadab Mohammed with us. His main honor, which will tell the rest of the things, is the receiving Padma Shri honor award by the government of given by the government of India in 2019. And we know how difficult to achieve that level. So it itself talks about his contribution to the field. Professor Mohammed is presently working as the head of the Department of Oral and Maxillofacial Surgery, King's George Medical University, Lucknow, India. And he is having more than 35 years of teaching experience at all levels, including the undergraduate, postgraduate, as well as at the PhD level. His specialty is oral and maxillofacial surgery with a special interest in the temporomandibular joint surgery, orthodontic surgery, maxillofacial trauma surgery, and dental implants. He has more than 200 publications in reputed index, national and international journals, and he has published many books in the field of oral and maxillofacial surgery. He has received many national and international fellowships, including he is a fellow of Royal College of Physicians and Surgeons of Ireland, fellow of the Royal College of Physicians and Surgeons, Glasgow, as well as the fellow of National Academy of Medical Sciences, New Delhi, and some more to follow. And he has received multiple awards. And the most important award I have mentioned previously, in addition to that, he has received the Best Dean Award, UP Rattan Award, and many other. So without taking much of the time, I would like to invite Professor Shadab Mohammed to go ahead with his presentation. Over to you, sir.
Thank you. Am I audible?
You are. We can see your slides, but they are not in the presentation mode.
Right. We are just doing it. Just wait.
Sure, sure. They are good now. Thank you.
Okay. Thank you very much, Dr. Nurul Anwar, Chairman, International Oral Cancer Congress. I'm really grateful to you for selecting me to give a talk on oral submucous fibrosis, various surgical modalities, and as you know that this condition is very much prevalent in this part of the country, and it is because of the habits like betel nut chewing in this part of the country, and it is as I said, it is a chronic kind of the disease and can affect any part of the oral cavity and sometimes pharynx also, and it is associated with the vesicle formation into the oral cavity, and juxtaepithelial inflammatory reaction is always there, and that may lead to the fibroelastic changes of the lamina propria, and that is the main cause for fibrosis of the oral mucosa, and ultimately it leads to epithelial atrophy and stiffness of the oral mucosa, and patients come with the difficulty of inability to open the mouth, that is trismus. So if you see a patient of oral submucous fibrosis, you can diagnose it from very far distances because patient won't be able to open the mouth properly, and all the area or the cheek will be sunken off and hardly there will be any mouth opening. It depends on the grade of the submucous fibrosis the patient is suffering with. History, if you look into the history, this condition has been described from way back to 600 BC by Shrishruta as a Vedari, and 1952 Schwartz describes it as atrophica idiopathic mucosa oris, and the present term submucous fibrosis is being given in 1953 by Joshi et al. So the worldwide number of cases is about 2.5 millions, and day to day it is rising because of the habits. If you look into the India, it is very much prevalent. It is about 0.2 to 2.3% in male population and 0.2 to 4.6% in female population. And most of the time nowadays, very surprisingly, the young individuals are also being involved because of the lot of gutka chewing or habit betel nut chewing or the pan masala or whatever it is chewing. And it is reported from 11 to 60 years of age. And worldwide, if you see that about 10 to 20% of the population consumes areca nut in various forms, and that is the main causative factor for developing this kind of the condition. Basically, etiology, if you see, it is because of the chronic irritation. Maybe it is because of the betel nut or chilies or tobacco or the lime. Sometimes it is because of the nutritional deficiency also. And metabolic disturbance is also may one of the predisposing cause for developing this condition. And some individual who has got genetic susceptibility may also develop this condition as well. So if you look into the pathogenesis is main pathogenesis is that areca nut consumption, and which is the main culprit. It contains various alkaloids like ericolin, ericadine, ericolidine, guaiacolin, and guaifenesin. Ericolin is the principal causative factor in development of the oral submucous fibrosis, which leads to the fibroelastic proliferation and increased collagen formation into the cheek mucosa. Apart from that, there are flavonoid components like tannin and catechin, which also enhances this kind of the fibrosis formation into the oral cavity. And these alkaloids, they undergo nitrosamination and give rise to the N-nitrosamine, which have cytotoxic effect on cells. So these are the causative factor for this. Because of the betel nut quid chewing, there is a constant irritation of the oral mucosa, and that because of the constant irritation, it leads to the inflammation of the oral mucosa, which activates in terms of T cells and macrophages at site. And there is increased cytokinins, IL-6, TNF, IF-alpha, increase in growth factor, TGF-beta. So these are the basic pathogenesis, how it develops, how the fibrosis takes place into the mucosa. ये क्या गया? Okay, am I audible? So that leads to the increase in collagen production and decrease in collagen degradation. So because of the increased collagen, that is insoluble cross-linking of insoluble form of collagen. And these collagen are responsible for fibrosis and development of the oral submucous fibrosis. Ericolin or tannins, there is an upgradation of TIMP1, cystatin C, and downregulation of MMP2 and 9 and internalization. Because of the decreased collagen degradation, and increased inhibition of collagen phagocytosis. Because of the decreased collagen degradation and inhibition of the collagen phagocytosis. So there is increased collagen formation, and that collagen formation is responsible for fibrosis of the oral cavity. And based on the clinical findings, this oral submucous fibrosis is being staged as stage 1, 2, 3. Stage 1 can be treated with the medicinal treatment, but if it advances into the stage 2 or stage 3 or 4, that needs a surgical intervention, which very often we do it. In stage 1, patient may complain of only burning sensation and some reddening of the mucosa or vesicles. But in stage 2, there is a fibrosis of the vesicle and ulcers, and the mucosa become blanching, and there are 5 palpable bands are there into the oral mucosa, and which leads to the marble-like appearance of the mucosa. Stage 3 will lead to the leukoplakia, and there is a severe space or hearing difficulty. Sorry. Based on to the mouth opening, it has been classified as group 1, 2, 3, 4A and 4B. If the mouth opening is more than 35, it is group 1. And if the mouth opening is between 26 to 35 mm, it is a group 2. If the mouth opening is 15 to 25, it is moderate to severe disease. And in severe cases like grade 4 type of the submucous fibrosis, mouth opening is only less than 15 millimeter. And in group 4B, extremely severe pre-malignant or malignant transformation of the submucous fibrosis can occur. If you see the clinical feature of this condition, early OSMF will lead to the burning sensation. There may be formation of the blister of the oral mucosa. There may be ulceration, excessive salivation, and defective taste sensation, and there may be xerostomia because of fibrosis. In advanced cases of OSMF, there will be a blanching of the mucosa, slightly opaque, white fibrous band will be there into the vertical direction if you just palpate it, and there will be shortening of the uvula because sometimes if it is involving the posterior palate, it will also involve the uvula and there will be shortening of the palate. Patient will not be able to whistle or the blow, or there may be a difficulty in swallowing because of the salivation. There is a decreased salivation and sound of the patient can also be changed. So if it is not properly addressed in time, there are chances that this OSMF can transform into the malignancy. The rate of transformation is less than 7% and less than 7%, which has been reported in various studies. So sometimes it changes into the malignancy also if it is not being treated properly. The treatment of this condition is always restriction of habits or behavioral therapy. So the treatment can be defined as medicinal therapy, surgical therapy, or oral physiotherapy. Medicinal therapy works very well when it is a grade 1 kind of the submucous fibrosis. Various drugs have been used as a modulator of inflammation like steroids, interferon gamma, placenta extract, and immunized milk. Steroids, if you use, it reduces the pro-fibrotic inflammation and enhance pro-fibrotic immune-mediated pathways. Like betamethasone, triamcinolone, acetonide can be used as a topical agent. Also, we can use hydrocortisone, methylprednisolone, dexamethasone, triamcinolone, diacetate for intralesional injections. These are given as a conservative management. So buccal mucosa has been divided into the 9 quadrants, and each quadrant we deposit about 0.15 solution of these medications. Then interferon gamma can also be used. It down regulates fibroblast proliferation. So it decreases the collagen formation. It has immunoregulatory effect, which is known as anti-fibrotic cytokines. Placenta extract can also be used. It is an aqueous extract of human placenta, which contains nucleotides, enzymes, vitamin, amino acids, and steroids. It simulates metabolism, increases vascularity at the local site, promotes regeneration and recovery of the tissue. No contraindication and results are found to be lasting. But it also helps in cases of early stage of submucous fibrosis, not the advanced stage of submucous fibrosis. Yes. Then immune milk is also being used as a treatment. It is a kind of skim milk produced from the cows, and it has got multiple human intestinal bacteria It has got a good anti-inflammatory effect. It contains moderate amount of vitamin A, C,
There is some technical glitch
yeah,
actually
just
with Dr.
doing it.
Sada.
Don't worry. Don't worry.
Yeah.
But yeah. So apart from that, is it okay now? Hello?
Yeah, you're audible, sir.
Okay. So nutritional supplements can also be used to correct this condition. Whatever there is a deficiency, if you just restore it, that condition can be revert back, which promote the normal cellular process present in the health, improve the epithelial atrophy noted in oral submucous fibrosis, and improve tissue healing. Like zinc, magnesium, selenium, manganese, and iron therapeutic agents can also be used to improve this condition. Zinc is also many times used to correct this condition because of it is a chelating copper. Red tomatoes or diet supplement like fresh fruits or green leafy vegetables can also be used to correct this condition, and green tea included in the diet chart can also help to relieve some of the condition. So these are the various micronutrients and minerals: milk, lycopene, pentoxifylline, interferon gamma, or steroids, which usually is being used for conservative or non-surgical management of the submucous fibrosis, but with a little bit effect. That is very effective in cases where it is very primitive or the grade 1 kind of the submucous fibrosis, not in advanced cases. Most of the advanced cases, they need a surgical intervention like hyaluronic acid and dexamethasone, placental extract, and turmeric also can be used to treat this condition. Now, surgical management, which most of the time, once there is a advancement of this submucous fibrosis and there is a lot of collagen formation to the cheek, patient is not able to open to the mouth, patient is having difficulty in eating, nutritional status is also affected. So these patients come for treatment of submucous fibrosis. Then generally it happens in grade 3 and grade 4 type of oral submucous fibrosis. So what we do, like first thing, because of there is a formation of fibrous tissue into the cheek area, we go for fibrotomy, like scalpel fibrotomy can be done, electrocautery or laser fibrotomy can be done, but each of these modality have got some limitation and advantage. So if after this doing this fibrotomy and mouth is not being open to the about 4 to 5 centimeter, 4.5 centimeter, then we go for coronidectomy, because coronoid process is the process where the temporalis tendon is attached and which is a strong elevator of the mandible. So if you neutralize that process, you can get an additional mouth opening about 1 centimeter. Then if there is a teeth which is irritating to the mucosa and leading to or adding up to the fibrosis, then extraction of the third molars are also being done. And then reconstruction of the mucosa can be done in various methods. I would be telling in slides. Various flaps can also be used for reconstruction once you do the fibrotomy. Like most of the time we use buccal flap, tongue flap, palatal flap, nasolabial flap, temporalis flap, platysma flap. Distant flap can also be used if there is a very big defect which cannot be corrected by this local flap. Then we have to make use of the radial forearm free flap or anterolateral thigh flap. Then grafts. Grafts can also be used to cover the defect which we create after the fibrotomy, like split skin graft, collagen membrane we can use, artificial dermis, or human placenta or amniotic graft can also be used. So first use of a transbuccal transformation of a nasolabial. Nasolabial flap can also be used for reconstruction of the defect. It is very near to the defect and can cover the defect about 5 centimeter. Nasolabial fold can be based inferiorly or it may be based superiorly, or it is a bilobe type of the flap. Axial pattern based on the branch of the main supply of this flap is because of the branches of the facial artery. So I am just showing you some of the cases which of the nasolabial fold. Like this is a patient where if you see there is a sunken cheek because of the fibrosis and decrease and no mouth, nil mouth opening at least. So this is the fibrotomy and opening of the mouth has been done. Like about 4 centimeter of the mouth opening has been done by the mouth gag. Then this is the raising of the nasolabial flap. This is the incision marking. You can have a single lobe flap as well as a bilobe flap. It can be attached superiorly or inferiorly based flap. Then these flaps, they are tunneled into the defect and sutured into the intraoral, as well as this is the extraoral suture. And this is the post-operative mouth opening. And this is a picture of the patient showing treatment, surgical treatment of submucous fibrosis by nasolabial fold flap. So this is one of the option, treatment option, surgical treatment option. This is another case. This is the marking of the nasolabial flap, which is based on the branches of the facial artery. And the flap is raised and it is tunneled. This is the raising of the flap. Flap reflected, full thickness flap is being taken and it is just transposed intraorally, and bilobe flap can be also be used, which can be covering a better area. So this is again a patient of nasolabial flap after suture has been removed. And see there is a hair also, skin. But in due course of the time, this hair goes off. And patient has to go under physiotherapy to increase the mouth opening. So this is the post-operative mouth opening where we have used the nasolabial fold flap. Very commonly used, very easily accessible, and having very good result because it is bulky, does not resolve, and it always remain in place. Then this is a patient of submucous fibrosis being treated by platysma flap. So once the defect is very large, we raise the platysma flap. And this platysma flap, once it is raised from the neck area, it is just introduced intraorally and the suture defect is being covered. So this is another option, like platysma flap is again an option for bigger defect treatment of oral submucous fibrosis. Then laser fibrotomy is also being indicated for treatment of oral submucous fibrosis, but only the disadvantage of this therapy is that there may be a lot of scar formation if the patient is not following the physiotherapy protocol properly. there may be again recurrence, and which is further very worse. Again, that may lead to the surgical intervention again. So laser is also one of the tool for doing the fibrotomy in cases of submucous fibrosis. Then lateral thigh flap can also be used. As I told you, sometimes the defect, it is involving the palatal mucosa up to the uvula area or whole of the vestibular area. Then these small flap cannot be used. We have to use a bigger flap, like skin from the thigh can also be harvested along with the fat, and then graft is inserted and suture in place. And in due course of the time, the graft becomes metamorphosized into the oral mucosa, and patient is put on a strict supervised physiotherapy regime. And this is again one of the patient where we do the fibrotomy, and after fibrotomy, the collagen membrane has been used to cover the defect till the healing takes place. So this is one of the again option. Then palatal flap can also be used for closure of this defect, which happens after the fibrotomy. Rotated palatal pedicle flap can be also be used. That is transposed from the last molar area into the cheek area, and that this is the patient with the suture defect with the island flap, little flap. Then this is the split skin graft, which is used to cover the defect. The graft can be taken from the thigh or abdomen, and this full thickness or split thickness graft can be taken, but full thickness is always better, or because the split thickness can later on resolve. So that is also being used. Like this is one of the again option, or like split of the full thickness graft is also an option for treatment of this condition. Then buccal pad of fat is very good because it is just into the near the vicinity where we do the fibrotomy. And Heaster was the first person who just mentioned about it. And this has got the 4 heads, and it is a bulky also, and can be sutured to the near defect submucous fibrosis, and it can be transformed into the oral mucosa in due course of the time. And the volume of the buccal pad of fat is about 8.3 to 11.9 milliliter, and it can be used for the covering the 3 to 5 centimeter of the defect. This is one of the patients which we are showing here with the treatment after fibrotomy. We have just filled the defect with the buccal pad of the fat, and it gets epithelialized. Thus, the tissue may revert back to the relative normal state. It is very easy to assess. No extraoral scar, intraoral grafting or take-up can be done. So it is very good for treatment of the submucous fibrosis. So this is again a case which is being treated with the help of buccal pad of fat. This fibrotomy has been done, and perioperative mouth opening about 37 millimeters being obtained. Buccal pad of fat being grafted and just filled into the defect. Periphery is sutured with a surgical defect. Then buccal pad this is the sutured buccal pad bilaterally. Most of the time we do the harvesting of the buccal pad of fat bilaterally, and it is sutured. Then this is the harvesting of the split skin graft. This is the Humbee's knife, which is being used for split skin grafting. You can use the full thickness as well as split thickness. This is after fibrotomy. This graft is being positioned over there and being sutured into the periphery, which can be removed after 7 to 10 operating day. And there is a very good uptake of this split skin graft. Then, then superficial temporal fascia. Superficial temporal facial flap can also be used. This is the temporal area. We have just raised this pedicle flap, and below this zygomatic bone, it can be tunneled inside after fibrotomy, the defect, and can be sutured. It has got a very good vascular supply because it is attached here. So blood supply of this flap is anterior and posterior branches of deep temporal artery middle temporal branch of superficial temporal artery, and it is a vascularized flap. So take-up is very good, and it gives very good supply to the fibrous mucosa. But the advantage is because it is a bit distant. There may be the formation of the scar, but that can be camouflaged into the hair present in that area if the proper incision is being given. Then these patients where there is a mouth opening, because it is reversible. Once there is a collagen formation, it is very difficult to, there are always chances of recurrence. So just to prevent this recurrence, most of the patients, they have been advised for the long-term physiotherapy, and various gadgets are available. Like this is the Hister mouth gag, which can be used under the supervision of a doctor or the trained doctor or a physiotherapist. So that will add up to the end result of the treatment, because if the patient is not being supervised properly for a long term under a doctor, there are chances that further there is a recurrence and decrease of the mouth opening. So these are the various surgical treatment modalities which generally used at our center, and is also been described in various literature. They have got some limitations and advantage also, but in the early stages of submucous fibrosis, it can be treated with the medicinal treatment. But in most of the time, grade 2, 3, and 4 type of the surgical submucous fibrosis, surgical surgery is the better option, and that gives a good result in long term. Thank you very much.
Thank you very much, sir, for that beautiful presentation. With your permission, we can allow the audience to ask 1 or 2 questions if they have any.
Sorry for the bit interruption in between interruption. That because of the net problem.
One question is coming in the chat box, Dr. Ruwan.
Yes, just
What
give
is
me
that?
a see. There's a question in the chat box. Oil pulling is also advised. How it is beneficial in grade 1 and grade 2 OSMF?
Which thing?
Oil pulling. I'm also not following what.
Oil pulling?
Yeah, oil pulling is also advised. How it is beneficial in grade 1 and grade 2 OSMF?
I'm not getting question. What is oil pulling?
Yes, same here.
Maybe some exercise, balloning or something. Oil pulling, what is it?
Dr. Yagvi Sharma, she has asked the question. Dr. Yagvi, can you unmute yourself and ask question?
What is oil pulling? Hello?
That question was put it into the chat box and we asked the person to speak, but unfortunately it looks like that.
Because I am not getting the point what she's asking about oil pulling.
Yeah.
Any other question?
In the absence of any other questions, we would like to take this opportunity to thank you for your wonderful presentation and enlightening us in the surgical management of oral submucous fibrosis. Thank you, sir. Thank you very much.
Thank you, Dr. Nuranagar, for giving me opportunity to speak. Thank you very much.
Thanks. So now we have the privilege that yesterday there is a talk scheduled to Dr. Shakti Singh Deora, but somehow he was in transit and he was not able to reach the destination on time. Dr. Ivan, I'm taking your permission. I'm continuing with the next speaker.
Yes, please go ahead.
Yeah. So we have with us Dr. Shakti Singh Deora. He is head and neck cancer surgeon, and he is he's a microvascular reconstructive surgeon practicing at Northwest Cancer Hospital Institute of Head and Neck Surgery, Ahmedabad. He is trained in head and neck oncology from India's prestigious institute, Mahavir Cancer Sansthan, Patna, Bihar. Dr. Shakti Singh at his world-renowned cancer center, Memorial Sloan Kettering Cancer Center, New York, as an intermediate and an international visiting scholar. He previously worked in different cancer institutes of Ahmedabad like SCG Cancer Hospital, Narayana Hospital, and Apollo CBCC Hospital. Dr. Shakti is trained in microvascular surgery from Chang Mung Memorial Hospital, Taiwan. He further trained in scapula freeze flap for maxillofacial reconstruction from University of Munich, Germany. Dr. Shakti amongst the handful of surgeons who exclusively practices both ablative and microvascular surgery with an experience of more than 12 years and more than 800 plus microvascular reconstruction surgeries in last couple of years. Over to you, Dr. Shakti Singh Deora. I think I have made you a co-host. You can share your slide.
Okay.
If I left anything in your introduction, you can add
No,
on.
thank you for your kind words and appreciation. And at an outset, I would like to thank Dr. Nurul for inviting me on this platform on oral cancer on this occasion of World Cancer Day. So I think I will just share my screen with you.
That's beautiful.
Just 1 minute.
That's visible.
Okay. So am I audible?
Yeah, you are audible.
Okay, thank you. So I am a basically maxillofacial surgeon, and I belong to the community of dentistry. After practicing for so many years in oral cancer, what I have learned is we should train our colleague doctors, our family, our colleague professionals because they have a pivotal role in oral cancer caregivers team. If I divide basically the oral cancer care into 5 parts, so first is the prevention of oral cancer, wherein the prevention we as dentists, I say belong to the family of dentistry. So we as a dental professionals have a role in cancer prevention because we are the first oral physician. We see a patient comes with a habit of tobacco, supari. We have a role in habit cessation, habit breaking counselings, tobacco cessations. So, breaking the habit, looking for any sharp edges which might cause oral cancer, or improving the oral hygiene of a or of a general patient who is walking into a clinic. These are the important things where we play an important role in prevention of oral cancer. The second part is the detection, early detection. Now, we as a dentist, again, I say the oral cancer is totally painless. It's not a symptomatic in early stage of cancer. So, what a patient should do it, ignore the symptoms. कि यार मेरे को दर्द नहीं हो रहा है, मेरे को तकलीफ नहीं है, मुझे क्यों जाना है किसी डेंटिस्ट के पास या किसी के डॉक्टर के पास में? अगर मैं जाऊंगा कहीं मेरे को वहम में डाल दिया तो so there are a lot of things from a patient perspective they think of, or they just visit a nearby shop and they just say कि यार वो छाला है मेरे को कोई दवाई दे. People they give the medicine, whatever the lignocaine gel or dento gel, something like that. So patient is relieved of the symptoms. So early detection can only can be done by we as a dental professionals. We need to learn the oral examination from the cancer perspective also. Third part comes is the treatment aspect. Now, when it comes to treatment is divided into oral cancer treatment is divided into the surgical oncology or the surgery part, wherein surgical oncology, ENT, maxillofacial surgeons, and MCH head neck surgeons are involved into the surgical part. Then comes the radiotherapy, and then comes the medical oncology. So in a broad way, if I say the treatment is divided into three ways where a surgeon have a very limited role. Now fourth comes the rehabilitation. Now, as we all know, if a cancer patient undergoes a treatment, he is going to a lot of of symptoms or side effects of radiation, surgery, and many things. There are oromusculature is totally distorted. There are loss of teeth. The jaw is deviated. There will be some hole in oral cavity. Various aspects. There are various side effects of this oral cancer. So these patients need to undergo rehabilitation by prosthetics, speech therapy, exercise therapy, kind of physiotherapy. So there are various aspects of rehabilitation wherein we as a dentist again play a very important role. Then comes the follow-up. So all these 5 stages of oral cancer caregivers team, we have the role at each and every part of oral cancer treatment. Again, I repeat that we have a very, very, very important role. So all the idea behind coming to you, talking about the basic thing that we need to train our people, we have read all these things in undergraduation, but it is just we need to open our mindset towards the oral cancer caregivers team also. So with that, I'll start the presentation. Okay, so we are going to talk about the oral cancer, these fun facts of our oral cancer. But I know that since 2 days this is going on, people are talking about oral cancer, oral cancer, oral cancer. It's how we prevent it, what are the etiology. There are a lot of things. I will go little bit deviated from that, and I'm going to talk about specifically what can a dental surgeon can do to a cancer patient. So I'll not get into much fact about it, but one fact is very true is that 5 people in India die every hourly because of this oral cancer. As I said, oral cancer is diagnosed at very latest stage or in advanced stages where the prognosis is very poor. Secondly, because of the geographical isolation, because of the inavailability of surgical oncologists, because right now
There might be some technical network issue, I think, with Dr. Shakti Singh. He get disconnected. I think he might be joining again, and then I'll make him coach and we can start repeat his presentation. Sorry for the inconvenience. Can you unmute Dr. Shakti?
yeah,
Yeah.
sorry, there was some disconnection.
Not at all. Yeah, you again
Yeah,
share
I'll
your
just
slide.
share it again. Not a problem. I'll share it again. It's fine. Is it visible?
Slides are not visible.
Not visible?
No,
Wait a
no.
minute.
Yeah, please. It came for a moment, and then it disappears. Yeah, it's coming again.
Yeah. Okay, so we were here at the limited access to health providers. Now the third is this affects the very low socio-economic group because of the high exposure of this use of tobacco and pan masala. But now I think we are very thankful to the government of India and state government, that under Ayushman Bharat, the treatment of these cancer patients is almost free, whether it's surgical oncology, the cancer treatment in terms of surgery, cancer treatment in terms of chemotherapy or radiotherapy. So now the financial barrier is almost taken out or taken care by the government, but now the barrier remains is this barrier, wherein the mental blockage is the barrier where still people are not coming on early stages to us. Lastly, I would like to say that the oral cancer is a visible cancer. It's not a hidden cancer. Anyone knowing it, anyone who is aware about the signs and symptoms of oral cancer can easily find out that I have a problem and I need to visit a doctor. So I think that is where training the healthcare professionals will make a landmark difference in early diagnosis of oral cancer. So as I said, almost two-thirds of people who do not know that the dentist also can do the oral cancer screening, and that is where we started a program 3 years back, education for cancer for dental professionals. So this program was basically associated with the Gujarat University, and we have trained around 1,000 dentists across the country, wherein we are training dentists or dental professionals that how you can do the examination, how you can manage these oral cancer patients. At the same time, we are giving a certificate that they need to put into the clinic. Let patient know. Let all your patients who are visiting to a clinic should know that a dentist is a competent authority to diagnose the oral cancer. So that was the idea behind developing this course of education for cancer. So now, before I conclude this, I would want you to answer this question at the end of the meeting, that if not us, as I said, how important our role is. And if we do not play our role, can we make any difference? No. So before I conclude this presentation, I am sure that I'll convince you that your role is very important. And if not now, when? Why we should wait for another 2 years, 5 years to accept that yes, we are part of Oral Cancer Care University. Let's start right from today that yes, I will be the part. Take a pledge on this oral cancer awareness, oral cancer day, that yes, I as a dental professional will be the part of oral cancer awareness commando force. So etiology of oral cancer, I think everyone have spoken about it, various aspects of tobacco, pan masala. I'm not going to get into details of this. Now, straight away, I will go to a very important topic, how a general dentist and a community dentist, what their role can be. So their role is in oral cancer awareness. Every dental professionals, they play an important part in oral cancer awareness. Let everyone who is practicing in whichever part of the country, whichever part of the world, make sure that I will be spreading the awareness of oral cancer into the general population who are near me. We don't tell you from east you come to west and do the oral cancer awareness. No, we just want you to do the oral cancer awareness near around your clinic, around your place, for your people, your society. The second is the research. Now, as we all know that in India, the research was, at very low level, or we were not very much research oriented. But now with the advent of, or with the government supporting the system of this research aspect, it is very important that now we are into, we are into research also, and there are a lot of research is coming into the picture, and I would want you people also to be actively participate in the research activities. Now, as I said, dentists play an important role in detecting oral cancer. These are various articles. If you see on the internet, there are thousands of articles wherein if dentists play a role that can improve the oral cancer survival. Now, how does this oral cancer survival is improved? Because they have diagnosed in an early stage. So an ounce of prevention is better than a pound of cure. So why do we say that? So I always tell my patients that if you are diagnosed on a stage 1, you will not require to undergo a major surgery. You will not be required to undergo big reconstructions. Just a small surgery or a limited surgery will help you out. Wherein that is also going to give you, the finances also will be less. The pain will be less. There are many things which, if we prevent it, or if we can detect in early stage, that can be prevented. Now, what is our role in early detection? Early detection, why do we need this early detection? If you go through this figure, please concentrate on this figure which I am telling you today. That 5-year survival for localized disease is 76%. The 5-year survival for metastatic disease is 19%. This is the data which is available on an international platform. But if I tell with my experience, it's hardly 5 to 7%. The people who report to us with a metastatic disease, 5-year survival is just 5 to 7%. Imagine that 70% of the people or the patients who have been diagnosed in our country are these metastatic disease. So that is the reason that people have a fear. If cancer ho gaya, that means they will die soon. Because most of these patients are reported with a metastatic disease to neck or some other part of the body. Now, early detection is often possible. Yes, as I said, oral cancer is a visible cancer. We can detect early. So, probably the signs and symptoms of oral cancer also have been taught to you. I'm not going to get into details, but I'll just tell 2-3 specific points. Is any ulcer which doesn't heal for more than 2 weeks need to be evaluated. Any ulcer that bleeds spontaneously, some kind of red white patch, we call it as a erythroleukoplakia. Please do not ignore erythroleukoplakia. Any unexplained mobility of the tooth also should be considered as a symptom. Some kind of nagging pain in the mouth. Patient always says कि मेरे को इधर ऐसा लगता है कुछ चल रहा है. I have some pain, but clinically there's nothing visible. So at times you never know, there are kind of intraosseous carcinomas. So patient will come with symptoms, but unfortunately you will not see any symptom. For that, you need to take help of the radiology to diagnose if there's an underlying disease or not. Anything which is difficulty in swallowing, difficulty in speaking, difficulty in moving tongue are also the signs and symptoms of cancer. Now, how we diagnose these cancer patients? How we detect it? Detection that requires 2 important things is a history taking. As I said, if you take the history taking means, if you say that how long is the duration of this ulcer, patient says ये तो 2 महीने से है, मेरे को कोई problem नहीं है लेकिन इसमें. That means that the time frame is very important. If a patient comes and says, हाँ मेरे को ना 7-5-6 दिन से ही तकलीफ हो रही है, छाला हो गया है, do not consider that as malignancy, but put him on surveillance. Any ulcer doesn't heal for 2 to 3 weeks, your ear should stand up. That there is some problem, dear. So keep this patient under the surveillance. history of the patient in terms of the family history, history of tobacco, history of history of what do you say, the pan masala, history of smoking, every family history, habit history, medical history, all should be noted down. Any previous surgical history. So history taking is very important. This has been taught in third year of our undergraduation. But unfortunately, when we come into practice, we limit ourselves. We put our barriers like how the horse has a barrier. मुझे सिर्फ इतना ही देखना है. I don't want to see this side or that side. I am very focused. No, that doesn't mean that you're focused. In that focus, at times you miss many things. So I would like you to take history. Give just 2 to 3 minutes. Just 2 minutes will be enough to elicit complete history of the patient. Then comes the clinical examination. Clinical examination is basically divided into two aspects. This, as I said, this is from what you have learned in your undergraduation. So that's divided into systemic and that's divided into local examination. Systemic examination, if a patient has probably the icterus, pallus, there are various things which you need to know. But specifically now I talk about the local examination. The local examination means examination of neck is very, very important. What we do is we just see with the mouth mirror and we think that we have done. No. Always examine the neck by putting your hand. Have some tactile sensation. Just move your hand in the neck. Just see for any swelling, any pain, any tenderness, any lump, any kind of the abnormality in the neck. That this has to be evaluated. So local examination, it is inspection and palpation. Do not forget the palpation aspect, my dear friends. So dentist should identify with risk factors. Now, if some patient come with ulcer on tongue and patient gives a history of the tobacco, pan masala, then you will think, yes, this can be a cancer. So staff should be trained also to take in our setup. If you have a nursing staff, then he should be trained enough to take the complete medical history. So I'll not get into all these details. Now, examination, again, I said probably you might have, but this might have been discussed in by my previous speakers. So I'll just brush a bit that you need to do a thorough oral examination. Again, I say simple 2 minutes job. Look for interior, look for tooth, floor of mouth, look for the lower vestibule, lower GBS, upper GBS, palate, tongue, throat, and base of the tongue. So these are specific points you should just see. Just take up the bulb, start from one side, do the complete examination, and done with that. Then you can treat whatever dental treatment the patient needs. So now, if we talk about the pre-malignant lesions, I think this also been covered in a covered extensively in last 2 days. What are the pre-malignant lesions and conditions? But now these pre-malignant lesions and conditions have been clubbed together, and these are known as potentially malignant disorders. Okay, so this is the definition of potentially malignant disorders. So what are these potentially malignant disorders? Just to brush up through few things, I'm going to just talk it about. Leukoplakia, we all know there are various types of leukoplakia. We see in your practice, you will see every now and then, if you're in some rural areas, you will see a lot of patients, those who are smoker, those who are the pan chewer, tobacco chewer, they will come with these kind of leukoplakias. And there's not painful leukoplakias are not painful. So patient will be, living with this leukoplakia for a long term. But we need to understand that these leukoplakias have a malignant potential of 0.3 to 10%. Erythroplakia, these are red patches. But take my message today. If you see any patient with a leukoplakia, do not leave that patient कि बाद में देखेंगे अभी आप चले जाओ. So what important thing I would like to draw your attention is all leukoplakia should be treated adequately. Then comes the leukoplakia. Why it need to be treated is they have a malignant transformation of more than 23%. So 23% of this patient with the erythroleukoplakia will undergo malignant transformation, and this is a very high ratio. So as I said, oral cancer screening, very important. Just do the lymph node examination. These lymph nodes are, I'll not get into details, but just look into the patient's, the patient's neck. If you feel any lumpy or any swollen lymph node, please note that this lymph node should be examined on a regular basis. Because I tell you a small story before I go ahead. One of my friend who was a periodontist, he happens to be, he was examining one patient other day, and he just saw a small lump in a 11-year-old child. He was treating on other side, but when he was holding it, he just saw that दूसरी side में there is something abnormal. So, he, after treatment, he just called me. He said, यार बच्चे को, I thought because there's an infection on this side, patient को lymph node तो इधर होना चाहिए, but patient has a lymph node on this side. So now what is this? Then I said, see, do not ignore any of these symptoms, especially in young populations. So what he did is, he has he was advised for his sonography. When sonography, USG was done, there was multiple lymph nodes in the neck, wherein one lymph node was taken out, sent for histopathology, and it turned out to be non-Hodgkin's lymphoma. So the young patient, 11-year-old patient, came for a dental treatment, diagnosed with a non-Hodgkin's lymphoma, treated and cured with that. So understand your importance that one periodontist with just one intervention save the life of that patient before it has spread to other parts of the body. See, those who are listening to my talk today, I'll tell you, saving a life doesn't mean that in emergency giving a CPR is saving a life. This is more important. By doing the oral cancer screening, if you save a life of one patient, you've saved a life of a family. So that becomes very, very important. So do not ignore to examine the neck. Imaging. Now, if you have any doubts, do not hesitate to do the imaging. Now, IOPA, we all have, OPG should become the basic X-ray if you have any doubt in any of the patient, whether it is swelling, mobility of tooth, whether there's a lesion. OPG should be in basic X-ray. You should get it done, because now wherever you are practicing, now the availability of OPG is very good, even in the rural areas. Ultrasound, as I said, you need to refer to a sonologist. Ask your friend or colleague to do what you are actually looking for, and communicate with the sonologist. If it is required to do any pathology, FNAC, get it done, and then review the patient. CT scans and MRI, we all know, will not get into details, but if you need, please advise, do not be hesitant to get the imaging done. One important point I would draw the attention of all the people who are listening to me today is, before you advise for CBCT, we are all fascinated with, getting a CBCT done. CBCT is only for hard tissue evaluation. CBCT doesn't give any information about soft tissue. So do not advise if you see any symptom of cancer, the CBCT. In that case, the CT scan with IV contrast only should be advised for evaluation. PET scan, if somebody has a cancer, patient is not willing for biopsy, what you can do is you can ask the patient to get a PET scan done, and then convince the patient to do the biopsy. Histopathology, as we all know, we need to send it to laboratory and they will tell you what is the diagnosis. How do we do the histopathology? Number one is FNAC, punch biopsy forceps. Now, this punch biopsy forceps, this is a very unique thing which probably we have not been taught in our undergraduation or in masters. But when I have joined, when I started my this onco training, I see this very nice instrument wherein you can do the biopsy at very ease. You just need to spray, take a bit of the tissue from the lesion, Again, from same lesion, take from the center of the lesion 2 bits. That's all. We forgot all those things wherein you need to take normal tissue, diseased tissue, then send it. No, gone are those days. Just this punch biopsy technique is so easy and simple that every dentist practicing in whichever corner of the country can do this punch biopsy. Because whenever you tell a patient that you have a disease, you have a cancer, do not tell until and unless you have laboratory report ready with you on a table. Do not just give your decision that जाओ तुम्हें तो कैंसर है करा लो कहीं से इलाज. No, I request all my dental colleagues, do not tell your patients that you have a cancer, go to higher center. Please diagnose the patient. Have some compassion. Tell the relatives that we are sorry, but this patient, this relative of yours is now diagnosed with a cancer. He will need some treatment. Please get the treatment done. And then I will be here to do the rehabilitation. I will be here to do the follow-up of you. So do not just send the patient, even if you are not treating, but you are the part of the oral cancer caregivers team. So please, if you want to learn more about this punch biopsy techniques and others, we have the workshops across the country. You can just write to us and we can enroll you for these workshops. Incision biopsy, as I said, gone are the days wherein we used to take biopsy from the normal tissue. Now we just take the biopsy from the center of the lesion. So this punch biopsy, if you're doing it, hardly you will need to do this incision or excision biopsy techniques. Excision biopsy, I tell you, I am not wrote here, but excision biopsy, please do not do any excision biopsies in your practice until unless you are sure that this is not a cancer. If you have a small suspicion that you might have, this patient might have a cancer, please do not do incision biopsy. Just do incision biopsy, no excision biopsies. The problem with excision biopsies is once you do the excision biopsy, now we as a surgical oncologist do not know what are the margins. It becomes very difficult to take the margins now. And we end up in either taking out more of the natural tissue which is not required, or sometimes we compromise the margin, we violate the virgin's planes of oncology, and we end up in the failures. So please do not do excision biopsy until unless you are very sure that this is negative. True cut biopsy, this is just for information. Yes, we do teach this kind of true cut biopsies, that how we take it. This is for lesions in the tongue, lesions in the neck, the lesions in the alveolus. Many times it becomes difficult that if you just take the upper portion, you get the varicose hyperplasia. So these are the punch biopsy techniques which usually we also taught in our workshops. Further section, I will not get into details. Now the treatment of cancer. See, I told you when I started my lecture that the treatment of cancer is divided into the primary treatment and the secondary treatment. So primary treatment is done by surgical therapy, surgery, radiotherapy, and chemotherapy. The secondary treatment, if I say, the secondary treatment is done by prosthetic rehabilitation. Every patient who is going oral cancer treatment will require some or other kind of prosthetic rehabilitation. The dental needs means if they have dental pain, trismus, the radiation caries, or after that, if they develop any kind of dental pain that need to be addressed. The physiotherapy for mouth opening, for neck, for shoulders, the physiotherapy is very important. And most important is the diet, because they will require very high protein diets. So modality, surgical modality, the role of maxillofacial surgeons. Now in our country, many people, even our colleagues, do not knew that a qualified maxillofacial surgeon is a competent authority to deliver the oral cancer care services. Now, when we talk about the radiotherapy, or when we talk about the role of dental surgeons in this cancer treatment. The first is the dental prophylaxis. See, every patient who's undergoing who's undergoing the cancer surgery, they should undergo the oral prophylaxis. Many a times I have seen the surgical oncologists doing resection, leaving behind kilos of calculus in the oral cavity. And that calculus gives us the secondary infection that leads to flap failure, necrosis, delayed wound healing, and whatnot. But thankfully, I am from a dental background, and we do a very proper planning wherein we take our dental colleagues. The dental oncology is one of the established department in my hospital, wherein every patient need to undergo the dental prophylaxis. There's a dental information form wherein which tooth need to be extracted, which tooth need to be restored, which tooth need to be kind of required for any tooth to be extracted in the line of your resection also should be marked. And most important is the fluid application of these patients. The second is surgical resection. Now, we all do the surgical resection, neck dissection, and reconstruction is done with loco-regional or microvascular free flaps. So I'll not get into the higher ends of reconstructions. Basic need is early detection and prevention. So preoperative planning, what all we do, as I said, we are not going to get into again details. We talk to the patient, we do OPGs, we do the examination, periodontal evaluation, any caries teeth, oral hygiene and dental compliance. Now, I tell you, if you have read about the etiology of oral cancer, now hardly people talk about very important etiology, that is the poor oral hygiene is the etiology for oral cancer. Now, that is the reason that in our country, most of these patients, they develop a second cancer because the oral hygiene remains poor even after the first surgery because they have not visited dental surgery. So, maintaining an oral hygiene is at most important to prevent second cancer. Okay, so these are the things which I'll not again get into details of this. Now come the rehabilitation. As I said, the rehabilitation should be taken into consideration before we do the resection. So that means in the pre-dental evaluation. So what we do is if any patient is going the palatectomy or going for maxillectomy, we need to take the impression beforehand, make a plate, make the interim dentures and insert it right at the time of the surgery or post surgery in the hospital setup only. So preventive rehabilitation, restorative rehabilitation, supportive rehabilitation, and palliative rehabilitation. These are the stages of rehabilitation. So this is for the any maxillofacial if they're learning, if they're listening to my lecture, that the oral cancer treatment when was started was actually taken care by the maxillofacial surgeons. But over a period of time, the maxillofacial other horizons were developed, and maxillofacial surgeons have diluted the specialty with the orthodontic surgeries, the rhinoplasties, aesthetic facial surgeries, which are more promising and which are more lucrative, and that is how the dilution of oral cancer with other specialties also happened. Adjuvant therapy is we do give radiotherapy and chemotherapy, as this just for your knowledge. So now, what are the side effects of radiation? There's a very important thing. If you have seen any cancer patient, or when you are going to see a cancer patient, you will see all these things. The mucositis. The first thing patient will tell, मुंह में जलन होती है, सब छाले हो गए हैं. You look into the patient's mouth and say, अरे मेरे को तो कोई छाला नहीं दिख रहा, because there's a thinning of oral mucosa and the nerves are very much near to the surface, so they have a lot of burning sensation. Saliva is altered, and that means this is xerostomia. You must have heard about xerostomia. Now, xerostomia is decreased in salivary flow. Now, saliva is antibacterial. Saliva prevents the caries, and when there's a decrease in saliva, the high chance of developing a secondary caries. And when there's a decrease in saliva, as I said, antibacterial, antifungal also. These patients might develop dental infection, altered taste, trismus. These are short-term side effects of the radiation. There are a lot of long-term side effects also, but these need to be maintained or need to be decreased or need to be intervened by the oral physicians or dental professionals. So dental consideration and chemotherapy patient, again, I'll not get into much detail into it. So now, before I just want to tell you that we want all of you, those who are listening to this talk, we want all of you to be the part of this commando force. We all can join hands and help every citizen of the country in preventing an early diagnosis, in giving them good quality of life care to these cancer patients. So this is chart. If you see that this patient, is well taken care by a dental professional at many aspects. Now I'll talk about dental oncology. Now I'm the we from the Asian Head Neck Cancer Foundation. We are working extensively to introduce the concept of dental oncology in our country. Now dental oncology is nothing out of the box. It is just a part of specialized dentistry which deals with this oral cancer or cancer patients per se, the oral health and dental health of these patients who are undergoing cancer treatment. Now, there are various procedures which specifically a dental, which specifically this cancer patient needs. So these dental professionals are being specialized or they are oriented to provide all those services. So dental oncologists also provide, the periodic care during and after the cancer therapy. The dental oncologist provide general dental treatment, including restorative dentistry, but they also treat and manage oral side effects, the sequel of cancer therapy, such as mucositis, candidiasis, and xerostomy. So, sorry. Just one. Okay, so there are in Western world. When I visited Sloan Kettering Cancer Center, I've seen that there's an established department of dental oncology, but in our country, the dental oncology is still in the embryonic stage. So we need to work hard to develop the dental oncology as a subspecialty of dentistry in our country, and let every cancer hospital across the country should have a dedicated dental oncology department. And that is only way we can deliver our services of prosthetics to improve their outcomes and their quality of life. Prosthodontist, as I said, plays a very, very important role. But unfortunately, there are limited training centers for prosthodontists, probably other than Tata and Amrita, where they have been not trained. But I would wish that many of these training centers develop and you become, and every prosthodontist give their role in rehabilitation of these cancer patients. So I'll not get into these details of free fibula, dental implants and all. So now, before I wind up, I tell you, if it doesn't challenge you, it won't change you. So accept the challenge that yes, I will be the part of this oral cancer drive across the country. I will be the part of this commando force against this cancer. Let's all work together, work as a team. So now, I think it is very important that if not us, then who is going to deliver these services? Do you think anyone? No. I'm very sure that with these 15-20 minutes of just a small introduction about the dental oncology and my view on dental professionals, you must be convinced with the fact that it is only we have an important role and we should start working right from today. So thank you so much for your patience listening.
Beautifully compiled, sir.
Thanks,
Thank you.
Dr.
Beautifully compiled. Yeah.
Yes, Dr. Sakti. You are being long time into training dental surgeons to opting for dental or oral oncology, and definitely by their effort and all, we definitely get all the cancer care hospitals are one dedicated dental oncology department, and dental surgeons are working there as a caregivers and all. So it's a very important to all of us who are, having dental background and those who are working in dentistry, that they should play a major role in managing the, caring for oral cancer patients and all. Because the detection is very important. So whoever is working in far-flung area, they should, do diagnosis as early as possible. So nice presentation. And it's encouraging.
Thank you, Nirmal.
Yes, your effort is there, and you can announce here as well that what you are doing, and people can enroll because most of them are dental surgeons here, and they are watching our program on the website. We are webcasting it, so few of them are available here in the meeting room, but most of them are
Yeah, so
watching out there.
we have a program by name Education for Cancer for Dental Professionals. So this program is dedicated. It is designed in a way. It's a 1 month training program wherein we have 3 online modules followed by an exam. So every week, or every Sunday, we have a talk of 2.5 hours, 2.5 hours of talk, which is delivered by a national faculty. And so we have 3 modules. Module 1 is about the understanding of oral cancer, habit cessation, and pain and palliative care. The module 2 is about the diagnosis of oral cancer that include imaging and that includes the biopsy techniques. The third module is about dental oncology, how we do it, how we manage symptoms, what are symptoms. See, today I covered in a very, very superficial way. But how do you actually manage dental caries? How do you actually manage ORM? How do you manage xerostomia? So these details are given in our course. And at the end of third module, we have an exam. So those who clears with 50% of the marks, they will be eligible to attend for our workshop. Now, when we started that was COVID time. So now we have incorporated Ioccon 2.0, wherein we started with the offline workshops. So now we already have 4 centers in our country, and we are trying to expand. By this year end, we are going to have 30 centers across the country, and I wish that every state will have one Ioccon workshop centers in our country, wherein the dentist can go to nearby place, get their training, and we just need to train and we keep them in the loop. It's not just training and forgetting. We have a line to line program. So those who completes the Ioccon program, they will be enrolled into Ioccon clinic projects. So now we have a program which covers from all the aspects. Those who are working wants to work for a long term, I think that is where you can join hands with us, and let's all try to fight this oral cancer. Secondly, on this occasion of World Cancer Day, I am very happy to announce that Asian Head Neck Cancer Foundation have also started our workshop centers in Bangladesh and Nepal. So tomorrow we have a important session on Indo-Bangladesh conclave on dental oncology, and we'll be starting our the workshop centers even in the other countries like Bangladesh and Nepal from tomorrow. And we are looking forward to expand into the other countries like Sri Lanka and probably other Asian countries. So that is what our aim is. And I would like to definitely would like your support, Dr. Nurul, in expanding our services. And you have always been
Sure,
great to us. Thank you so much.
Sure, Dr. Shakti. So with the time constraint, Dr. Shakti, we are, with your permission,
Yeah,
I'm
yeah,
going
we
to the
should move
next
forward.
speaker. So we are fortunate that we have 3 back-to-back oral maxillofacial surgeon joining from different part of the world. We started with Dr. Manjula Attigal. He is a faculty and he is a dean faculty of dental sciences, and he is the oral and maxillofacial surgeon joined from Peradeniya University. After that, we have Padam Shri Dr. Shadab Mohammed, he joined from King George Medical College, Lucknow, and after that, Dr. Shakti Singh joined from Ahmedabad. So we have another oral and maxillofacial surgeon who is joining from Mumbai, Dr. Manish S. Tiwari. Dr. Manish, are you there?
Hi,
Yes,
I'm there.
yes.
Yeah.
So Dr. Manish is a consultant head and neck surgical oncologist in Kakino's Healthcare. He is a clinical trainer for global trial on flavoimmunotherapy. He done fellowship in head and neck oncology from Tata Memorial Hospital, Varanasi. Then he did fellowship in oral oncology and microvascular reconstruction under mentorship of Dr. Saidul Islam, Park Clinic, Kolkata. He trained his training in head and neck surgical oncology from Prince Ali Khan Hospital, Mumbai. And then he is getting training in head and neck oncology from Mazumdar Saw Cancer Center, Bangalore. So over to you, Dr. Manish Tiwari. If I missed anything, I have just taken an important point from your profile. If you want to add, you can better add, and then you can start your presentation.
Oh, no, thanks for sharing that. So, am I audible, Dr.
Yeah, you
Nurul?
are audible and your slides are visible, but it's not in slide share mode. Yeah, it's not visible. It's not slide share mode. Yeah.
Okay, so
Carry
without
on,
much delay, I think the time taken by Dr. Shakti was much needed, and that was more important topics than any other topics. In today's time, it's not really important to talk of surgeries and everything, but because by 2040, the WHO information is that the oral cancers in India are going to increase by about 50%. So that was a much needed topic. So quickly, I will go through my slides. My topic provided to me was recent advances in reconstructive surgery. So we will quickly see what of reconstructive surgery advances that I could found on this topic. So first of all, what is the need for advances in reconstruction? As you know, patients to a lot of functional deficit and also radical after radical excision, and that leads to a lot of difficulty in breathing, speech, mastication, swallowing. There are cosmetic issues also, like when you do regular PMMC flaps, local flaps, there are a lot of cosmetic issues that happen. So there is a need for advancement in that area also. And then also for advanced diseases, there is a lot of soft tissue and bone loss, and these things are there. So always there is some need for improvement. So there has been a concept of reconstructive ladder in head and neck surgery. And this concept means that one should always go from very simple reconstruction to a very advanced reconstruction. Like you should go for let the wound heal secondarily, and or do skin grafting, and then do local flap, and then go for microvascular surgery. That should be last thing to do. But in today's time, the ladder concept is discontinued, and we follow elevator concept. Whichever floor you want to go, you have to press a button and reach to that floor. So all these methods of reconstruction are important and have their place in head and neck surgery, but one should be chosen wisely. Like for tongue reconstruction, radial forearm free flap is the best reconstruction choice. Okay, because it is a pliable flap. It doesn't cause tethering of the tongue. Usually, if you do a local flap there, a PMMC or something, the defect will be closed for sure, but the tongue will be tethered. It will not move normally, and patient will not be able to speak well even after years of reconstruction. But with radial forearm flap, immediately post-operatively, you can see the results. So one has to choose the appropriate of his interest of elevator. So that is a new thing. That is why I have added. So microvascular surgery is a recent talk of reconstruction in head and neck. Am I audible properly, Dr. Nurul? Hello. Am I audible properly, Dr. Nurul? Oh, there is some network issue, I think. Why? Hello.
Yeah, you are audible, Dr. Manish.
Yeah, are you able to listen me? Am I
Yeah,
audible?
yeah, you are audible and your slides are visible, but somehow it was not moving at some point of time. So you can again make it in a slide share mode. Yes, now
Okay.
it's a bit microvascular surgery is visible.
Okay, so free fibula flap is a very famous now mode of reconstruction for head and necks. So you can bend the fibula in whatever way you want. You can create a midline defect. You can create a hemimandible, or even up to can go with this free. So followed by radial forearm flap. Okay, this is a tissue taken from the forearm of the patient along with its blood vessels. And this is used for, as I told you, tongue defects and also for buccal mucosa defects. So here is another example of radial forearm free flap. This patient had lip defect, and the lip has been reconstructed using radial forearm free flap. I have chosen this case just to show you that how you preserve the palmaris longus tendon there to recreate the oral competence. So in this case, because we have put the palmaris longus tendon here and on the superior aspect, recreating the orbicularis oris muscle and recreating the oral competence. That's why this case was chosen for this slide. So another case, similar case, so beautifully lip can be reconstructed and a functional competence can be achieved with help of radial forearm free flap. Then coming to ALT flaps, these are also very widely used for wherever you have a bulky reconstruction needed. We go for ALT flaps. Even for thinner reconstructions, now we nicely dissect out the perforators out of the muscles there, and we can create thinner flaps also. So these are basically workhouses. This is the rectus abdominis free flap taken from the abdomen. A large amount of soft tissue can be harvested here. So bigger defects can be reconstructed. So what clinicians should can go for like even large cancers that involve almost half of the face, and use this reconstruction technique to create the facial defects. Now, another announcement that has happened in the recon double free flap. Now, very often we have started using double free flap. In past 1 year, we have done about 5 cases of double free flap. So this is done for very large cases. Here, I have chosen this case to show you that how a large extensive cancer from opposite side here, premolar area to the RMT area. So there will be a need for large soft tissue defect, soft tissue reconstruction here. A bone that has to be also, there is a lot of a very big defect that is going to be created. So it's not possible for just one bony flap to reconstruct all these things. So we need a soft tissue that can line intraorally, and we need a soft tissue that can create the extraoral defect. So this is the surgical defect that was created after excision of this tumor. And we have taken a ALT flap and a free fibula flap along with a lot of lateral skin there. So yeah, this is the fibula flap that had been shaped like the specimen that has been removed. And this is the ALT flap that we took. And this is how we could recreate the bony aspect of the defect using fibula. And the skin that is lateral to fibula is used to recreate the oral lining. So like vestibule area of lingual and buccal vestibule has to be reconstructed using this skin. And then another ALT flap that was taken was used for extraoral reconstruction. And this is how this patient was reconstructed and was back to normal function and good acceptable cosmesis using 2 free flaps. So yes, double free flaps are another talk of town. Going forward, stereolithographic models are now widely used. So you can actually get a patient's skull or jaw printed in a stereolithographic material. So this is done to evaluate the exact size of the defect and even plan the surgeries and do the mock-up surgeries directly on the printed skull models. So that's about stereolithographic models. And then there is a CAD-CAM technique where computerized cutting guides are made based on the defect size. They will make computerized cutting guides, and these guides can be printed and taken into operation theater, and you have to just adopt them on the mandible and use these guides to do the mandibulectomy. So that will give you a very precise mandibulectomy. And at the same time, for reconstruction, we can print the cutting guides for free fibula flap. Like the fibula that has to be sectioned into a particular shape, it's usually, in past, it was usually done manually. Even now, many people do that. But now with the advent of this technique, exactly you have to cut the fibula in order to shape it like a mandible. So this is about CAD-CAM prosthesis. So this is a study that have compared the CAD-CAM assisted fibulas, and they have concluded that defects reconstructed with CAD-CAM assisted fibula experience superior postoperative function as compared to soft tissue flap or freehand fibula flap. Freehand fibula flap is the manual cutting of the fibulas. So that's how it's coming into practice now. The CAD-CAM assisted prosthesis, the cutting guides and all. Coming next is, so now there are many papers that have started demonstrating good outcomes with the use of implants in free fibula flap. So these implants can be planted, like here it has been planted digitally and properly. The same has been transferred into the patient. This implantation can also be done while raising the free fibula flap, while you are doing the primary reconstruction at the same time. After osteotomy, you can actually put the implants there, and the results are fairly good. So for your reference, Dr. Vinay Kumar, he's from Narayana Healthcare, Bangalore, has done a lot of this regard and demonstrated a good outcome of primary implants in fibula also. So yeah, this is how they do reconstruction using fibular implants. Now coming to customized implants. Customized implants are very patient specific. So initially we used to use recon plates like this. Okay, nowadays because of CAD-CAM techniques and 3D printing advancement in 3D printing techniques, we can actually print patient specific implants. So this has better shape of the mandible. This has a better adaptability to the mandible and better stability. And also this is made up in a very good biocompatible materials. And here in this example, you can see that another implant has been formed along with the temporomandibular joint in it. So these are the customized implants that are now coming into practice. Next is microvascular anastomotic coupler. So as you all know that in microvascular surgery, the most important part is anastomosis of the recipient vessels along with the flap vessels. But that is the exact part of the surgery that takes a lot of time. And also smaller inaccuracies while anastomoting the vessels can cause a lot of problems like bleeding or can the vessels. So anastomotic couplers can actually just anastomose the vessels. You have to make the vessel ends get into these anastomotic couplers. and you have to fix the vessel walls on these needles. Okay, and you just have to rotate these couplers, and they will basically anastomose the vessels to one another. So this is a very quick method, but the limitation is that it can only be done areas where you want to do end-to-end anastomosis. There are areas where we do end-to-side anastomosis, like we have to anastomose a vein on the IJV. In those situations, it becomes difficult to use this. So yeah, another very good advancement, and now in India, it's been frequently used. Coming to perforator flaps. So perforator flaps are basically a surgical technique related advancement. What happens is usually we used to take blood vessel along with the we do is we trace the perforators that are coming out of the main vessel and supplying exactly that part of the skin. Like in this example, you can see there is an internal memory perforators identified. Basically, we identify the perforators using audio Doppler. It's a technique where you can actually listen that what all places are the perforators. So now in this case, the perforator has been marked here. This perforator will be traced exactly to this point, and this much of skin will be taken and it will be transferred to another place. Suppose in this case, a tracheal, a pretracheal defect is there, and that was reconstructed using this internal memory perforator flap. So nowadays, there is a lot freestyle flaps that's been developed just because now we know better the anatomy of the perforators, and we have started relying on the perforator. Initially, we thought that smaller perforators might not survive, and the flap might fail in those cases. But now we are seeing that if we have safely identified and saved the perforators into the flap will survive no matter how long the flap is. The same is true for ALT flaps. In beginning, we used to take this lateral rectus muscle along with the flap. Now we trace the perforators up till the point where it is entering the skin, and this is how a very pliable thin flap can be raised, and you don't have to damage the muscles that are near the perforators, and the patient can have a better function and less donor side morbidity, and also a pliable flap can be obtained from the same area. So this was one of our case where we have done a perforator based ALT flap. Usually the ALT flaps are very large, like this big and very thick. Next, these are another advent in the area of reconstructive surgery. Initially, we loops anastomosis. Now we have microscopes that are multi-axial and multi-user this thing. So here you can see the surgeon and the assistant both can see into the microscope at the same time. At the same time, there is one more eyepiece that is not used here that can be used by a third person standing there. So 3 people at a time can look into the surgical field at their convenience. These are multi-axial microscope. So if you want to keep your head straight, you can adjust the eyepiece accordingly. So this is another area that has given surgeons flexibility, and more fine work can be done using these ergonomic microscopes. Next is tissue engineering and stem cell based research. So tissues can be regenerated, replaced, or repaired. Okay, so usually tissue engineering is something they have basically a scaffold, like there is a bony framework, and in those bony framework you have to put the stem cells, and then you can actually generate the bone out of it. So this tissue engineering is more in the field of bone and cartilage regeneration, but still mostly it is in a research phase and not very widely accepted into the. But in future, for sure, we can tissue banks where you want a mandible, you can just go and take out that much of bone from a lab and put it in your patient. So this into a and another thing that is coming into the fellow transplants. So rather than replacing multiple parts, doing multiple, what they have is another person's face on this person's face. Okay, they have replaced the soft tissues, the bone root, the vessels, the sensory and motor nerves, and everything has been replaced for this within one unit. So patient don't have to undergo multiple surgeries. So this has been done in about 35, 36 patients worldwide so far, and the results are quite satisfying. Problem is for this kind of allo transplants where another person's face has to be transplanted for a lost face, lifelong immunosuppression is needed. So with this, I thank you all for your patient listening, and thanks Dr. Norul for giving me this opportunity to speak. Thank you so much.
Thanks, Dr. Manish, for sparing your time. I think you are invited somewhere else today for your talk, and you finish the talk, and ultimately you join on time. Yes. Any question from audience? They want to ask any question for reconstruction surgery. They can ask. They can get their query answered. I think there is no any question. If they have any question, Dr. Manish, stay with us for say another 25, 30 minutes. Then we are concluding our session. If there any questions arises, we'll get back to you, and please give the solution of the query. Your net is a bit little bit compromising. I think we are not able to hear you thoroughly. Dr. Manish, are you there? Dr. Manish, are you there? I think Dr. Manish get dropped off due to network issue. So moving to our next session, I'm handing over to Dr. Ruwan Jaisinghe. He is the organizing secretary of International World Cancer Congress 2024. Over to you, Dr. Ruwan,
thank you, Dr. Nurul.
Yeah.
As the time is a factor, we will straight away go for the lecture, because I'm sure the people must be waiting to go for the work because of the weekend. It's a pleasure for me to invite Professor Dilip Silva. Dilip De Silva is a very senior consultant in community dentistry, and is a very good friend of mine. Before he joined in the University of Peradeniya Faculty of Dental Sciences as the chair professor of community dental health, he was the in charge of human resources at the Ministry of Health, which was the most responsible position in the Ministry of Health. And he was basically looking after all the aspects of human resources in the Ministry of Health. So he had vast experience in human resource development and various other aspects of finances. His pet area is health finances. And he's a very good researcher with large number of research publications and presentations for his credit. Without taking much of a time, I will invite Professor Dilip Silva to start his presentation. Dilip, over to you.
Thank you, everyone. Let me share the screen. Can you see the screen now?
Yes, we can, but it's not in the presentation mode.
Yeah, okay. Is it okay now?
Yeah, now it is okay. Go ahead.
Okay, thank you so much for your invitation, Ruwan. And it's an honor for me to do this presentation. So today I'll basically speaking about having listened to all the wonderful technical or clinical side. My topic today is on about the finances of the cancer treatment and how we manage in Sri Lanka from the Sri Lankan perspective. As we know, Sri Lanka has a very long history for healthcare, and Sri Lanka claimed to have the first delegated hospital from the whole world. not only from the Asia. It goes back to the 4th century BC. There are ruins in the ancient capitals of delegated hospitals going back to the 4th century BC. So coming back to today's context, though we are a small country with 22 million population and 65,110 square kilometers, very small country when you compare to our brother India, we have gained a lot of things in health. As you can see, this is a World Bank publication. The blue line are the under 5-year deaths. If you compare with the low middle income countries where Sri Lanka belongs to, and South Asia is the green one, and the reddish is the low middle income country. And if we consider the 5-year mortality rate, we are very much has a very lower rate. So we have a very developed health system from that perspective. And from the other angle, if you consider the life expectancy, when you compare with the South Asia and the low middle income countries, Sri Lanka is far above them. So our life expectancy is very high, and 5-year mortality as shown above in the previous slide is very low. So from the Sri Lankan point of view, as I said, we are dealing with 22 million population, and Sri Lankan Health Ministry is the second largest civilian ministry in the country. Our largest ministry is the Ministry of Education. In the Health Ministry, we have 150,000 employees, and they belong to 288 categories. And we have treated 58 million OPD patients, 7 million indoor patients, and 3 million clinic attendees. Why 58 million OPD patients? Repeaters. Some people come more than twice to the clinic. And we have a very small budget in the context of Sri Lankan rupees is about 250 billion Sri Lankan rupees in 2020, somewhere around that. Of course, now it's increased. So if I had to put in comparative terms, Indian rupee goes at about 4 Sri Lankan rupees to 1 Indian rupees now. So our budget is 250 billion Sri Lankan rupees. And this is our manpower. We have in the government service about 2,300 medical consultants and about 100 dental consultants, including OMF surgeons, 21,000 medical officers, 1,700 dental surgeons, and 43,000 nursing officers, so on and so forth. And government sector is the main provider for inpatient care. 95% of the inpatient care come from the government sector. Only 2 to 3% comes from the private sector. But when it goes to the OPD sector, it's 50-50. 52% from the private sector and 48% from the government sector. So I'm speaking today mainly of the government sector, which we cater for the almost 95% of the Indo treatment and about 50% of the OPD treatment. So this is the manpower in the government sector. And one may, in Sri Lanka, the total education, including postgraduate education and the medical education, is totally free, totally free. And this is our cost. One of my publications, and dentistry course is the highest, most expensive course as anywhere in the world, in Sri Lanka too. It costs about 8.6 million Sri Lankan rupees to train a dental surgeon for the 5-year degree. And for the medical doctor, it costs about 4.1 million. So it's almost double, more than double. And Sri Lanka trains the specialists free of charge. Sri Lankan government spends about 15 million Sri Lankan rupees for a postgraduate training course spanning from 5 to 6 years. And at the moment, since we are speaking of cancer, we have trained 71 clinical oncologists trained from this free health system, and out of which about 55 to 60 are in the country. And when you see though we have achieved good health, as you can see, our share of GDP on health has never exceeded 4%. The blue line is for Sri Lanka, and the red line, as usual, for the low middle income countries, and for green is Southeast Asia. So we are spending less than 4% on GDP from both the private sector and the government sector. But from the government sector, we are spending less than 2%. Actually, it's 1.9% of the GDP on health. So this I put the total health expenditure over the years, as I said, in 2018, from 2013 to 2018. What I want to highlight is the last column. We are spending about now 25,000 per capita on health in Sri Lankan rupees. This is an important graph. I'll draw your attention to the two lines in the middle, the red and the green. What you can see is the red is the Sri Lankan government expenditure on health, and the green is the private sector. And you can see in 2006, these two lines crossed. Earlier, the government was the predominant supplier of health Sri Lanka until 2006, and in 2006 onwards, the green line, which shows the private sector, overtakes the government sector, and now the gap is getting wide. So though we have a free health system, now the private sector plays a pivotal role. And our funding comes mainly from the domestic funding. As you can see, the domestic funding on the graph on your right, more than 90%. The purple one is domestic funding of our health budget. We get only very few donations of foreign aid. And even if we get foreign funds, we are getting by the way of loans, not by grants. And as a developing country, we do spend very little on capital expenditure. When you compare with recurrent expenditure, our recurrent budget is always about 80%, and the capital we are spending less than 20%. And these are the budgetary allocations, as I told you earlier. Last year, it was estimated to get about 323 billion Sri Lankan rupees. We have come a long way from 169 billion in 2018. And we have a dual system of the line ministry, that the central government and the provincial councils. So we have 9 provincial councils, which they look after the primary healthcare and the low-end medical care hospitals, where the high-end hospitals are looked after by the line ministry. So out of the healthcare funding, the domestic sources of funding predominate the public health expenditure. So we are not getting much foreign aid. And between 1915 and 2001, the domestic sources of financing accounted for 95% of health financing. And the donors' contribution is very less. And even that small amount comes from in the mode of loans, not grants. Going back to our functional classification of health spending, out of our health budget, the government health budget, nearly 2/3 or 67% goes for hospital care. That's including cancer care. Coming back to the private sector market, because we have a very vibrant private sector too, it's an oligopoly market, meaning there are 5 big players in the market. So they are enjoying more than 80% of the market, our 5 big hospitals in the private sector. So they are the market leaders. Therefore, the small guys cannot enter the market because it has the oligopoly features of undercutting the small guys coming into the market. And the private sector, we have about 35,000 to 38,000 employees. And in Sri Lanka, the doctors and the paramedical staff, that is physiotherapists, pharmacists, occupational therapists, so on and so forth, they are allowed to work in the private sector after government hospital hours. So we call it dual employment. So government sector employed doctors, the consultants, and the paramedical staff, they can work in the private sector after hospital working hours. So that supplements our private sector. And private sector on its own have a very limited number of staff, which is about 35,000. Coming back to cancer, our topic today, in Sri Lanka, from all cancers, about 100 cases are reported every day. And in 2021, we had 37,000 new cancer or incidents, about 37,753 new cancers, and males 17,000 odd and females 20,000 odd. And out of which, ladies and gentlemen, the main site of cancer, as you know, in Sri Lanka, males, 15% of the cancer of the males is accounted by lip, tongue, and mouth cancer. In the females, the breast cancer, and oral cancer comes beyond the 8th or the 9th level. So in males, it's the number 1 cancer, accounting 15%. And in year 2021, the crude rate was 25 for 100,000, and we have had about 2,600 lip, tongue and mouth cancers reported in the government and the private sector. And as I mentioned, 15% of all cancers, and we are having 103 new cancers. So out of our current budget, we are spending 45% on inpatient management. That is to manage patients within the hospitals. And from our budget, 1/3 is spent on NCD, which includes under non-communicable diseases, the cancer care, cancer treatment is also included. And the government, in leading government hospitals, we have about 1,100 government hospitals altogether. And in the leading government hospitals across the country, we have cancer treatment, both surgery and in identified centers, chemotherapy and radiotherapy. And the government also have 2 delegated cancer hospitals, which provide all free cancer care. And the private sector is coming up in the cancer treatment perspectives. We have 2 private sector institutions mainly targeting cancer treatment. They are internationally affiliated. One is affiliated to the American Oncology Institute, which has treatment centers across Southeast Asia. So there's another center newly started for comprehensive radiotherapy treatment. Oh, this is an interesting thing. In the Sri Lanka, people do not come for cancer treatment, as anywhere in the Southeast Asia, at the early stage. So there's a costing study by Hemant Amarasinghe et al., and it has showed if a patient comes at stage 2, it will cost the government 59,000 Sri Lankan rupees for the management. But if the patient comes at stage 3 and 4, it will cost 3 lakhs and 3,000. That is 6-fold increase. So the early patient or early diagnosis will save the government money. And if you are diagnosed at stage 3 or 4, it's going to cost 300,000, which is about nearly 6 times of the money spent by the government as against diagnosing at stage 2. There's another study, again by Hemant Amarasinghe et al., and it says the total economic cost of tobacco-related cancer for Sri Lanka, this is not only oral cancer, tobacco-related cancer, is a staggering amount of 121 billion US dollars, and out of which direct cost of smoking is 35% and indirect cost. So direct cost is the cost beared by the government. So for the Sri Lankan government, which spends only around 250 to 300 billion Sri Lankan rupees, the cancer care costs a substantial amount, though there's no mega studies to analyze how much cancer costs, but we are sure it consumes it is calculated under the NCD program, and it costs a substantial amount of money and the workforce, because out of our 21,000 doctors, at least 300 are involved in direct cancer, and we have about 80 consultants, including OMF surgeons. We have about OMF surgeons, oncosurgeons, general surgeons, also sometimes handling other cancers, but oral cancer mainly by the oncosurgeons and the OMF surgeons, and it's all free. So the cost to the government is massive. So with that, I conclude my speech. Thank you very much. These are my references. Hello.
Yes, you are audible.
Ruan, any questions, please?
Any question from audience? They can ask questions related to, the cost incurred to manage cancer care in Sri Lanka per se. So anybody who want to ask question, they can ask question. Dr. Ruwan, are you there? I think Dr. Ruwan connectivity might be an issue. So nice presentation, Dr. Dilip. You have summed up that what is the the economic burden of this cancer in the perspective of Sri Lanka. Anyone want to ask question from Dr. Dilip? Dr. Dilip, there is no question. So we are, this was our last but not least, the last session. We are concluding for the day. We are signing off the for the day. There are some announcements for tomorrow's sessions. We have some 16 speakers who are joining tomorrow. We are talking about margins in oral cancer by Dr. Asim Mishra. Recent trends in prevention of oral cancer will be spoken by Padam Shri Dr. Ravi Kannan. Then we would be, Dr. Ruwan will come again and he will talk about teledentistry in managing OPMD. Then we have one session on chemotherapy, current trends in treatment of oral and head and neck cancer. And then Dr. Abhishek will come and he will talk about loco-regional reconstruction options in oral cancer ablative defects. Then there is a one speaker joining from Turkey. She is Dr. Aksun Some. She will talk about radiotherapy and dental implant application in patients and head and neck cancer. Then we have Dr. Bhushan Gade, radiation oncologist, will joining from Pune, and he will talk about what are the recent trends in managing oral cancer, what about the radiotherapy and all. Then we have one speaker joining from United Kingdom, Dr. Kehinde S. Khan Modi. And then we have robotic surgery we are included, and what is the trends in managing oral cancer through robotic surgery. Dr. Vishal Rao joining from Bangalore. Then Dr. Abhishek on behalf of Dr. Sunil will joining from Uttaranchal. Then we have some post-surgery care where we have impact of technology in maxillofacial prosthetic reconstruction rehabilitation by Dr. B. Srinivasan. And then we'll talk about the quality of life by Dr. Sanket Keti Reddy, and ultimately the pain and palliative care is in oral cancer were taken by Dr. Vivi. So this is all about tomorrow's session. We are signing off today. We'll start by 10:30 tomorrow. If any audience want any question related to organization of this program or any feedback, they can share the feedback. The day one we have faced some problem while logging in with this delegates, that they are not able to log in with their email IDs, but now all the the problem is already sorted out. So still anybody have any problem, they can connect, they can write an email to us, they can connect directly to us through WhatsApp or through phone. So it's a very fruitful day today. We have 2 speakers joined from Sri Lanka and 4 from India, and we have in depth, we have completed all the surgical aspects, mostly head and neck and surgical aspects, because oral surgeons are the highlights of today's session. So there are 4 oral and maxillofacial surgeons who have spoken. There are 2 surgeons who is dropped due to they have some emergency surgery, so they can't join. So with this note, I think Dr. Ruwan, are you back?
Yes, I am back.
Yeah, yeah.
Sorry, I had a very
Dr.
something
Ruwan
urgent
for
to.
closing comment, and we'll then sign off.
Thank you, Dr. Nurul, and I think we had a very productive session today, even though there were a little bit of hiccups, some technical issues, and some speakers were called due to some very urgent matters. But still, I believe that we had a very productive session, and the important areas were discussed in detail. So we are looking forward the same participation contribution tomorrow as well, because we have a few important lectures lined up for tomorrow as well.
So Dr. Ruwan, I am seeing that one of the member from advisory committee of our International Oral Cancer Congress, Dr. Syed Ahmed, he is there in the meeting room. Dr. Syed, if you want to add anything, you can add. Otherwise, we are signing off. Yes, Dr. Ruwan, so we are signing off for the day, and we are
So we'll meet up tomorrow morning.
Yes. At 10:30.
Yes, 10:30. Have a nice day.